Um, so just to kind of talk about what this class is. So I have a little bit about me. I've been a bereavement nurse um, for 10 years in the military. I was part of a bereavement committee when I first became a perinatal nurse when I was first actually in postpartum, and I was in a GYN med surg unit that's very similar to 3 South. Um, and I originally wanted to become a nurse in oncology, and my director told me, "Well, I think you should be bereavement because somebody that is interested in oncology might be a good fit for bereavement." So I joined the bereavement committee, and I really found that I could recognize why it was so important to specialize in that area. And um, I I found that I was able to provide the patients the attention that they need. I'm going to turn on my camera just so there's something that we can see. So I had been in that bereavement committee at big military hospital in Virginia. And I got to see how we did it. We were really good about making sure that the resources were available for our patients, whether they were in the ER, labor and delivery, or the 3 South unit. We were also good about continuing a relationship with our patients. So somebody called our patients within about 2 days of delivery or discharge to check in on them. And then again at 2 weeks. And we did things like a candlelight service once a year for anybody that experienced perinatal loss. So we sent invitations to them. This was an optional thing for them to provide us with their address and phone number for us to contact them later. So the patients had opted into it, and it all went to one contact person. When I got to the Naval Hospital here in Jacksonville, I immediately wanted to be a part of bereavement there as well, and ended up becoming the bereavement chair for Naval Hospital Jacksonville. And that main person, that the person that contacted them 2 days after delivery, 2 weeks after delivery, was mostly me. I had a team, but a lot of times it ended up being me that was the primary person to contact them. So I've done it for a long time. And during that time, I taught a class called Resolve Through Sharing. So Resolve Through Sharing is a organization that specializes in bereavement. Currently, there is a class that's done here. I just haven't seen it scheduled in a long time. I had taught the class without ever being able to go to the Resolve Through Sharing coordinating class. I had done the original Resolve Through Sharing class, which is a 2-day course. And I had never been able to go to the coordinator class. It costs a lot of money, and at the time you had to do it in person, and there was never the funds to be able to send me. So other people had been able to attend, and they gave me the course to teach. So even though I was not a Resolve Through Sharing coordinator, I taught the Resolve Through Sharing course. So I say all that to say that at this point, I'm still not a coordinator, to be quite honest, but I do have over 10 years of experience in bereavement itself. So when everybody asked if we could do a bereavement class, I wanted to pull on my experience from doing the Resolve Through Sharing course, which of course I don't have available for me to teach right now. So I had to create this material kind of from scratch. Which is unfortunate because one of the things I really loved about that class was the fact that they had some amazing videos. So I tried to pull some videos that kind of put pieces together that were similar to the Resolve Through Sharing class. I would love your feedback on the videos. That is one thing I'll say about our agenda here that's a little bit different than what it says. So instead of having us listen to their stories um, all in like a 30-minute block, I have them broken out. So that way we're listening to one at a time within each section. Um, so I would love to be able to teach that resolve through sharing course. One of the things though that I've struggled with when it comes to bereavement and making sure that our staff, hospital staff, have the resources to take care of some of the most important patients you could possibly take care of. What I've struggled with is the fact of how expensive some of that stuff is. So I'm hoping that by creating this class and having 4 hours of CEs attached to it, and then potentially creating more classes, that we can make it to where it's not about the money and it's just about learning about how to take care of our patients and not trying to get some special course. Does anybody, can you guys tell me what are you hoping to gain out of this class? It'll kind of help me direct exactly where we go with some of the discussions.
I know for me personally, I want to know like when is the appropriate time to bring up certain topics with them because I know everything is really sensitive, but it's
Mm-hmm.
like how to better read the situation and how to better read the room with some of these parents and families because some of them don't care and then you have some, they're in such distraught, so it's just kind of hard like when to bring up certain things.
Yeah, I agree. Um, that is one of the I love that you said read the room, read the situation. I think that that's one of the most important parts of bereavement care is that going in there with the knowledge that you really don't know how this person is going to feel, how they're going to perceive this loss. Um, and that's kind of the first part of it, right? Is just walking in and assessing the situation and kind of writing the flow of the room. And I see chat, Alexa says, I want to be better equipped to assist individuals through a highly traumatic event with respect and best practices. Yeah, absolutely. Um, it can be, I find it can be very challenging to know what to say. It's sometimes it's good to have those phrases in your head that are like, this is not a good thing to say. This is not something I want to say. And we'll talk about that. Um, but at the same time, sometimes we have to give ourselves grace, right? And know that we are going to say something that we're not supposed to say. We are. I mean, I've taken care of uh, bereaved families for 10 years, and I would be lying to you if I said that I've never figured out, oh, I shouldn't have said that. I think it is it's important for us to know to give ourselves grace. And if we do say something that we regret saying or that we feel maybe wasn't the best thing to say, or maybe wasn't, even if textbook wise it was nothing that we're going to say, you shouldn't say this, but we can tell that it hurt our patients to just acknowledge and apologize to them. One of the things that I find with bereavement care, and it's probably the thing that I honestly get upset about, um, is that our I find a lot of staff almost avoid them. Um, and it's interesting because we're telling ourselves that it's because I'm giving them space. And there are times that absolutely they need space. If they have family members in there and they're all grieving together, that's one thing. But I do find sometimes they're giving them space when it's just somebody by themselves, or when it's a couple that's sitting there in silence. And I think we're sometimes that's absolutely what they need. And sometimes we're doing it because we're uncomfortable with the situation. And when we're uncomfortable with it, we avoid. Um, One of the things that I would do as a bereavement nurse, and I will, I'm not putting that out there that I am the bereavement nurse here. I will tell you that, but at the same time, I can't not um, be that role as well. So if you ever are taking care of a bereaved family and you're struggling, whether it's you're struggling with what to say, what to do, where to go, what resources we have, or even just wanting one more person maybe to reach out and connect with your patients, you can call me pretty much at any time. I I the I struggle with some of it because I have been put in situations where, um, as a bereavement nurse, all of a sudden I was now their nurse, if you know what I mean. And it happened not just in labor and delivery, but also in the ED, and the OR, because I was very accessible. So, but at the same time, I would rather the resources be out there and um, somebody to be accessible if you're needing that support. Anybody have any questions before we start? Anybody else want to tell me like what you're looking for with this course? I want to say I didn't have this in the slides, but I do find I'm going to kind of put this warning out there. It is anytime we're talking about perinatal bereavement, one, you guys might even be able to tell with me, like having years of done this, there are times that I struggle with it too. Uh, if you get to a point where this is too triggering, I do need you to stay on the course for 4Cs, but at the same time, take a step away. Um, Maybe even turn away from the monitor if pictures are too intense for you. Um, Allow yourself to feel those kinds of emotions and take that step away. It's also important for your own taking care of your patients. Even if you need to ask the charge nurse, can I just take 5 minutes, 5 minutes to step away and acknowledge my own emotions about it. It's important to recognize when we need that because that's going to help us have the capacity to take care of our patients, the emotions to take care of our patients. So I think that's really important to talk about. Bereavement care is definitely one of the more emotionally challenging things that we do in labor and delivery that most people don't realize and don't often think about when they go into labor and delivery. Let's go ahead and talk. And I did not mean to start out with those pictures. Okay, what can you guys see? Can you just see the agenda or can you actually see the slides now?
I just see the slides, but it's not in presentation mode. Like I can still see all the slides on the left.
Yes, ma'am, I gotcha. I haven't clicked on the presentation mode yet. Okay, now though you can see just a black screen though, right? You still can't see it in presentation mode. I'm gonna have to fix this one.
No, I see the PowerPoint, and then on the right side it says next slide with like learning objectives.
Yeah, I'm gonna have to fix this. Just give me a sec because that is not how I want it to be. Mm. Still not. Okay, now what can you guys see? Can you guys just see the slides?
Yeah, just the slides.
Okay. Okay. So, like I said, this is the introduction to perinatal bereavement. We're going to discuss perinatal loss, a little bit about the definitions of perinatal loss as well. Discuss some aspects to cultural and individual differences. And then discuss some of our communication skills that we can use. We're also going to talk about support for grieving parents. And this part is a little bit broken up throughout it, but discuss what they might need while they're inpatient, and then also what they might need outpatient as well, like once they're discharged. And then we're going to discuss some of the memory making and rituals that we can do to help support within that loss. So what is perinatal loss? So perinatal loss is kind of what we use to define an infant that is lost due to miscarriage, stillbirth, or neonatal death. And so we consider anything that's a pregnancy loss before 20 weeks, we define that as a miscarriage. Miscarriages can be defined in many different ways. It could be referred to as a medical, and as you guys know, in like the medical terminology that's used for a miscarriage, they do use the term abortion, right? When we are discussing it, we don't typically say even abortion. When we are definitely discussing with our patients, we would never say that term. But the way it is defined in that GTPAL is an abortion. And so the terms that they use when they talk about what the patient experience are going to be terms like medically induced abortion. You might see something that would be considered elective abortion. You could also see something that's considered a missed, and we usually use this term missed miscarriage or missed abortion, or threatened abortion. So what these terms are, when you have somebody that has something called a missed miscarriage, this is where we go to get the fetal heart tones before 20 weeks, and we do not find fetal heart tones. And so we know that, the baby has passed away inside, but the body has not gone into that miscarriage process. Versus a patient that comes in with bleeding and say they have bleeding, we do find fetal heart tones, but they have maybe even significant bleeding. They might define this as a threatened abortion. This would be like an ER term that they would use. That can honestly be hard for our patients to hear, because they think that threatened abortion just means that there's still a good chance. But sometimes in the ER situation, they don't really take the time to define that you have rapidly dropping HCGs, right? That human chorionic gonadotropin. So one of the ways that we can define or medically, we can see that somebody has a good chance of having a thriving pregnancy is to have doubled HCGs in 48 hours. So your HCGs would continue to increase and would be increasing at the rates that we see with a thriving pregnancy. So when we see that threatened abortion, you can see a threatened abortion where you have significantly high HCGs. And you can also see a threatened abortion when you have lower HCGs. And really discussing with the patient, sometimes it doesn't happen, where we don't really talk about the fact that threatened abortion, the chances are very high that this is going to continue and that they're going to have this loss. One of the important pieces is just remembering that this is a loss for that person, depending on how they perceive their pregnancy. So we'll discuss more of that in a little bit. But this can be anywhere between, a very early loss, 6 weeks, 8 weeks, but it can also be 17 weeks, 18 weeks. We typically see them more in the labor and delivery environment. And this is something kind of important to remember, because I have heard of from providers here even that nursing was frustrated because a patient was only 15 or 16 weeks and was taken care of in WAC. And it is important for us to remember that typically 15 weeks and up, it's actually best for them to deliver up, like in labor and delivery type of environment. They are, for their general health, at that point in time, you can't get what's called a dilation and curettage, like a DNC. I know DNC we always think about with postpartum hemorrhages, but they are also used for miscarriages as well. And less than 15 weeks, and I would even say less than 14 weeks, that is one of the typical managements that they would do for a miscarriage where it's an incomplete miscarriage or a missed miscarriage. After that period of time, they would do a dilation and evacuation, or dilation and suction. This process is not always as conducive to the grieving process as admitting and delivering. And it's not safe for them to experience that loss at home when the fetus is that big. So it's just important to realize that there's such a range of loss, right? So you could have that type of a loss, and then you could also have a pre-viable preterm labor patient. So if you have a 21 weeker, 22 weeker, and I do know that now there's been more resuscitations for 22 weeks and up, especially in like areas like Nemours, where they have, not Nemours, but Wilson's, where they have more resources. But as we know, the age of viability is defined as 24 weeks. 23 weeks is kind of that area where oftentimes they will also resuscitate as well. So when we have these losses in that 23 week, 22 week, 21 week, especially 22 and 21 and below, these losses can be even more complicated by the fact that they were so close to that age of viability. And then you have the next range of losses after that 20 weeks. So we can define that as a stillbirth. And this could be 2 different types that we might see. For example, you might have a baby that is has already been discussed as not being compatible with life. So that term is kind of an older term, actually, that not compatible with life. It is best defined as life-limiting condition, only because there are babies that have lived beyond what was expected medically. So life-limiting condition is kind of the recommended term to use in bereavement. And then you have babies who have, we have all already discovered that we did not find heart tones. The other part that you might, that kind of encompasses within that perinatal loss for umbrella is neonatal death. So this could be anything from a baby that is born and passes away within, 2 hours. It could be as much as a baby that passes away from SIDS in that first 28 days of a newborn's life, or also in the NICU. I will say, as a bereavement nurse, I was contacted for even babies that passed away from SIDS within the first 6 months, to be quite honest, because there's still such a need for resources. So let's kind of start with why we need to have this discussion. It's important for us to realize, and we'll discuss this more, especially with the videos, of how common this can be, as in like what the numbers really look like. 1 in 4 pregnancies end in a miscarriage. Typically that first trimester is where the majority of the miscarriages happen. But sometimes can be as early as the early second trimester part, right around placentation, which is when the placenta attaches to the uterine wall, which is about 14 weeks. That's when those risks really start to drop. And then 1 in 100 pregnancies end in stillbirth. And that is, that's been really the number that they've used in for a long, long time. It has adjusted, and then, as we'll discuss in a second, certain communities definitely have the higher rates of loss. 46% of individuals who have experienced pregnancies, so they would view the loss as equivalent of losing a child, and that's one of the things that we'll discuss more. But it's important to recognize that everybody experiences loss very differently, and you might have patients that, from the moment they saw that positive pregnancy test, they were dreaming of that baby in their arms. And you might have patients that feel a sense of relief when they have a loss, and that all of that is okay, right? And giving them that space to be able to express it. You might have patients that also feel guilty because they feel a sense of release. And that is also okay for them to be able to express, and trying to kind of give our patients that safe space to express these feelings are really important. One of the other pieces, so Black and African American patients experience some of the highest rates of perinatal loss. This has been the numbers for, for my DNP project, I had looked up numbers of adverse outcomes within communities, and this has been consistent for the last several decades. So some of the videos that we will watch are from the Black community, and that's one thing I would rather lift their voices up instead of discussing it myself. So that way we can discuss after listening to them. So I think it's important for us to recognize that our patients need our support and resources that are as accessible for them. And one thing I will kind of touch on also with that, about the highest rates of perinatal loss, it is also important just as us, for us as bereavement or as perinatal healthcare workers, to recognize that those rates are, even when we remove everything like things like equalizing education, equalizing resources, equalizing access to care, because I find that sometimes people try to rationalize numbers of our Black and African American patients having these higher rates of perinatal loss. They try to rationalize it by saying things like, it's because of access to care, it's because of education or this and that. And that is actually absolutely not true. When you remove every single piece of that and you even out every factor, they still have the highest rates of loss. And so I think that's a part where, again, and we've discussed it more with, it's been discussed a lot more recently, but we need to continue to constantly look at ourselves and do what we can do to remove those barriers in our patients' care, like implicit bias, like also holding each other to the standard of care that we need for our patients. There was a study that just recently, when I went to A1 on the Hill, it was one of the things that we really hit on pretty hard, was that our babies in the NICU, there was a recent study that found that when Black nurses and providers both took care of the babies in the NICU and were the primary healthcare workers, those babies thrived in comparison to when they were not being taken care of. And that, again, is one of those pieces where it just really, it means that we need to look in on ourselves and make sure that we are recognizing any bias that might be impacting their care and holding other people. So some of the outcomes of doing perinatal training, I think it's important for us to be able to know some of the sensitive ways for us to discuss with our patients loss. I think it's also important because having tools to be able to provide care to our patients during this incredibly sensitive time is critical, because I'm going to pause for one single second. I'm so sorry. Somebody just asked me if they can join the class, and I'm going to tell her yes. It is one of my previous orientees, so she's going to join a little bit later, but that's okay. So it is important because when we have tools to take care of our patients, not only is it better for our patients' care, but it's also better for us to have increased resilience, to know when it's okay to step away from that care and give yourself 5 minutes, or when it's okay to allow yourself to grieve as well. There are times that we talk about writing the room in bereavement. It can be anything from allowing yourself to follow those emotions with your patient sometimes, I can tell you stories of, crying with my patient. I can tell you stories of praying with my patient, laughing with my patient, because not everybody experiences grief the same, and that's okay. So some of the uniqueness of perinatal grief, it is a really complicated topic. our patients, and again, this is not everybody. Believe me, this is not everybody, and not everybody experiences any of this the same way. But our patients, they are experiencing loss of a child, you know, and kind of, I would say, we're going to define this one as the patients that are excited from the moment that they see that plus sign or those two lines, and immediately imagine having a baby in their arms. I had a patient who, the dad, from the moment he found out that they were going to have a baby and it was a girl, he imagined just walking her down the aisle. That was what he put in his head as the ultimate moment of being a parent. And that was the loss he felt when she was stillborn, was that moment was never going to be his. And it's important to recognize that we are providing care to patients that are going to be experiencing grief in so many different ways. I've had patients that have told me that, you know, one of the things that we do sometimes in our care can be referring to our patients as mama. I mean, how many of us do that, right? I've heard so many people do that. I've done that. Some of my favorite midwives have done that. And we've done that as well with bereavement. And I've had patients tell me that they didn't want to be referred to as mama. It felt uncomfortable. It was their first baby and it was a loss, and they just felt very uncomfortable with that. So it's important to ask them, you know, how do you want me to refer to you? And using names are always their name, the name that they prefer. One, it shows that you care enough to learn it. It shows that you care enough to remember it. Same thing with the partner. Remembering the partner's name, knowing the partner's name, and using the partner's name is a way to connect to people in a way that we don't connect to people anymore. You know, we've lost that art sometimes. It's a way that we can always kind of not make that kind of mistake of referring to somebody as mama that doesn't want to be referred that way. Same thing with how they refer to their babies. So one of the rules I have is to learn the baby's name, and I think we'll talk about it a little bit more, but learn the baby's name from the first moment you meet them. If they have a baby that has no fetal heart tones, or even if they have a pre-viable birth or any of those pieces, learning the baby's name from the very first moment that you meet them and writing them down so you do not forget. Writing down the partner's name or the support person's name so you do not forget is so important. It's also important to recognize how this topic can be sometimes a hidden topic. It's not, one of the videos will actually discuss this, but it's not talked about as much as I wish it was in our society. It is a heavily taboo topic, and we'll discuss this more when we get to some of the videos. And just to know that, you know, we can never really truly know what somebody else is going through. Kind of to understand that really it's like we talked about the dad that really wanted to walk his daughter down the aisle. Grief is it's experienced in relation to the significance of that parent's attachment. So, for example, you know, a patient who has just desired to be pregnant their whole entire life and see those two lines, that attachment and that bond is going to be a part of their grief. The same thing with a patient that maybe sees those two lines and feel stress. That is going to be a part of their grief as well. You could have a patient that, and this is kind of one of those things that I think it's important for us to remember when we're taking care of our patients, maybe to know their history a little bit. And then also recognize that we may never know truly their history of loss. I will tell you a tiny bit about myself. I had been a bereavement nurse for, 6 years, I think. 5 years was my first loss. So I've been a bereavement nurse. I've been a nurse for about 5 years. And I started in bereavement as soon as I became a nurse. So I've been a bereavement nurse for about 5 years when I had my very first miscarriage. And we had it at 11 weeks. And we were at a prenatal appointment. And I just remember my husband had come. He had brought my middle daughter now. She was my youngest at the time. And she was looking at the ultrasound with my husband. It was my friend who was a midwife that was doing the ultrasound. And my husband was talking to my daughter and saying, "Oh, do you see the baby? Do you see the baby? There's the baby." And my midwife, she was very quiet. And I knew her, we were friends. And I just looked at my husband. I said, "Stop, Ryan, stop," because I knew something was wrong. And that was the first loss. And within about 4 months, plus maybe 5 months, I had another loss. And then a month after my second miscarriage, I lost my father. He passed away. And that was one of the hardest losses I've ever gone through in my whole life. And a month after he died, I saw that positive pregnancy test. And I couldn't even look at it. I looked at it. My husband was like, "Oh, that's so great." And I was like, I can't even think about it. I threw it in the trash and I walked out of the bathroom, and I just couldn't even think about a baby at that time. And that ended up being my third little girl. And I will always give myself grace for feeling that way when I first saw it, because of course I wanted her, but I couldn't attach to that pregnancy just yet because of what I'd gone through. So it is just really important to know that our patients, they go through so much, and it may not just be about bereavement. It might be about a loss that they've already experienced. It might be about a loss with maybe they went through a breakup with their partner. Maybe they didn't go through a breakup. Maybe this was something that they thought was going to help their marriage. Maybe there's so many different pieces to it that really drive our grief. And so I think that's important to recognize. So when we look at the phases of bereavement and really of grief in perinatal bereavement, and I will tell you, this is more representative of the perinatal bereavement. There's also, of course, Kubler-Ross for grief. And I would say that bereavement applies there, but also there's ways that we can kind of break it out where it's just perinatal bereavement that we're looking at. So shock and numbness. This is that period of time where they may have just found out. This could be a patient that found out in WAC. This could be a patient that finds out in the clinic. We could have a patient that I feel like you could have everything from a patient that is experiencing more of a traumatic perinatal loss because they're going into preterm labor with a pre-viable baby, or a patient that has had months to think about this because they found out that they had a baby with a life-limiting condition early on. So when we're looking at the stages of bereavement, it's important to recognize our patients could be in any range of this depending on the situation. So this is usually that first period when they first find out. And they kind of cycle back and forth between these and don't always experience these specific characteristics, things like a short attention span. We always try to recognize that our patients might struggle with making decisions at that point in time, and that it's important to give them space as long as they're medically stable to provide that space. So there are times with a person experiencing an intrauterine fetal demise where, a stillborn, where it is critical to deliver them soon. If we have severe hypertension, or even just in general preeclampsia in this scope, or if we have signs of an infection or something along those lines, that makes it harder for us to give them that space to make a decision. But try to give them the space for that shared decision making kind of from the beginning, even if there are significant medical reasons on why. We still want to discuss with them and give them as much of that information as we can and pull them into that process as much as we can. Complicated grief encompasses perinatal bereavement, and it is important to facilitate as much of a grieving process without adding to it by having that shared decision making. It can be very difficult for them to make a decision in that period. So trying to encompass the best support network that we can is really important. So allowing for time, taking a step away, telling them what you're doing, of course, not the avoidance that I talked about, but saying, okay, well, we are going to give you guys time to discuss this, and we can come back at this time. Repeat, using the opportunity to continuously talk about it. And I will tell you, I do find that even though that this is a period of shock, and you're trying to provide space, making sure that they are also just prepared for what decisions there are to make, and kind of discussing with them what the expectations are. And we'll discuss that more when we get to discuss about admissions. Just really allowing them that space to make the decisions in the time is important. This is where we're kind of looking more at what happens afterwards. So this might be after they're discharged from us. This also could be when they are, when they found that their baby has a life-limiting condition. Just knowing that sometimes that struggle is not when they're in the hospital, it's after they go home. And we will discuss kind of more what we can do for that. But especially connecting them to resources can be so important at that time. They can start to feel anger. They can start to feel maybe even anger at their own care. Especially, that is one thing I will say. There has been a lot of research that has looked at perinatal bereavement and found that, and when I talk about that ignoring, meaning I don't mean ignore, but when we talk about avoidance of our patients, that's I'm not just saying it for my own personal experience. It is found in research that patients felt like the staff avoided them, like the staff stayed out of the room as much as possible. And maybe their staff was trying to tell themselves, I'm giving them time and space to grieve, but maybe that's not what they wanted at the time. Just making sure that they know that we're still there for them. And, and, it is not about whether it makes us feel uncomfortable or not. It, we have to be comfortable with that space. We have to be comfortable with providing them care. One of the things that can contribute to avoidance is guilt as well. I will tell you, I have seen perinatal bereavement care where, I had one patient, she went down to the clinic for her morning appointment. It was a scheduled appointment. And the provider had used the Doppler on her, checked fetal heart tones, wrote down 120s, and then everything about the appointment was wrong. She left the appointment, and about an hour later, she came to triage, and she said she was there for decreased fetal movement. She had not mentioned that during her prenatal appointment. And we found no fetal heart tones, and that provider constantly had to ask herself, did I check the maternal heart rate when I checked fetal heart tones? And that is something that can make a person feel guilty, right? That's something that can make a person feel like they did contribute to this. Now, by the time the baby was born, the chances were very good that the baby had passed away before she ever went to that prenatal appointment, but that guilt still exists. I've had a patient who, I'm going to kind of go back to that implicit bias, actually. So I had a patient, this was when I was pretty early on as a nurse, and I remember she came into triage, and she came in for decreased fetal movement, and we put her on the monitor, and everything about, what we saw for her NST was reactive. We had 2 good accelerations. We certainly had moderate variability. The only thing I do remember was during her contractions. I remember it looking more like marked variability during the contractions. That was the only thing that stood out. But overall, she didn't have many contractions. And overall, it was still moderate variability with 2 accelerations. And she was on for actually 40 minutes, but it was a textbook NST. And the provider came in and did an ultrasound. I don't think she did a full BPP from what I remember, but I do remember definitely doing an ultrasound, checking fluid. And I just remember I was standing there in the room, and I was very early as a labor and delivery nurse by this point. And I don't feel like I had developed my good nurse voice. And I remember her saying, I can't believe you don't feel these fetal movements. This baby's moving all over the place. You don't feel that? You don't feel that. And I'm just kind of staring at her like, how are you talking to her like this? And she walked out of the room and walked into we had like a little area where our 2 triage nurses and our resident would sit. And she said, she was referring to, it was an active duty military facility. And she was referring to active duty patients at the time. But she said, I can't believe people, they'll always try to find an excuse not to go to work. I'm so sorry, somebody's at my door. Just give me 1 second. Oh, no, that's not good. Okay. And she said, I can't believe she didn't feel that baby move. The baby was moving all over the place. And me and the other triage nurse, we had both actually just had babies, and we looked at her and we were both like, well, I know exactly what she's feeling, because I didn't always feel my baby move either. And it's very hard to sometimes know if your baby is moving. And it was one of those moments that, so kind of going back to what I did, when I discharged the patient, I had a whole talk with her about, well, we're telling you your baby looks good right now, but trust your own judgment. If you are concerned, please come back. Please come back for care, because I could see how horrible it was what she said to her, and just how it felt for the patient. I was watching her face. I just wanted to reassure her that she should come back. And I say all this to say, so she did come back, but not to us. She came back to another hospital about, I think it was a day or two later. And she had a fetal demise when she came back. And in the military, active duty patients, they have to be delivered, not have to be, but they are typically transferred to a military facility if they are stable. So she was transferred back to us. She didn't come back to us. She came back to another hospital. And that, for me, is a piece that breaks my heart, because I know that I feel like that was because she did not feel supported by us. And that resident that was so insulting to her ended up admitting her that day. And it was one of my first patients that I was involved from the beginning, not just from the bereaved part, but before the baby, before the baby was an IUFD. And I feel like it's one of those pieces, kind of going back to higher numbers for our Black and Brown patients, that of that implicit bias of, I feel like that played a part in how this provider perceived this patient and educated this patient and talked to this patient. And while I did my best at the time to try to repair how the provider had talked to her, if I could go back to that moment as a nurse, and as a nurse that has found my voice, I would have corrected her, and in a way that was supporting the patient and advocating for the patient, not insulting the provider necessarily, but do you know what I mean? In that room, I would have said, well, it can be sometimes difficult to feel your baby move, and we understand that. And it's important to know that you are the best indicator of concerns for your baby. If you're concerned, we're concerned, and we want you to know that we're there for you. Just lifting up their voice more. So encouraging support groups in that searching and yearning period. One of the things that we used to always do as well was provide resources. There are actually support groups throughout Jacksonville. There are so many support groups throughout Jacksonville. There are in person, there are online ones. And if we aren't already, just making sure that we're providing those resources. Can anybody tell me, do you guys already have a packet of resources for like support groups? Do you guys know? I know Tiffany or Kirby or Grace.
There's a printout in the bereavement room of like support groups. I think we have a little like a small piece of paper that we can like hand patients that has like support groups and other resources. I think if they need like help for like burial arrangements and etc.
Okay. Good. So just also recognizing that the experience of loss, it can actually last for a very, very, very long time. And sometimes one of the slides from the Resolve Through Sharing shows you that as they kind of experience those milestones as well. Like a year after their loss, they can have a spike in, you know, that disorientation or depression scales. Um, and it's one of the things that can contribute more to that complicated grieving process is that it's can be such an alone feeling, for the person, because they potentially don't have the same support system that maybe they had in that beginning period. If they did have support in the beginning period, um, they also might have, because of the fact that it's considered in our society, we struggle with this whole idea that it's a taboo topic. They may have never had really anybody know about it. So that can really contribute to that disorientation. And so kind of making sure that we have the support groups, and that we are providing them resources is really important. It's it can be difficult, but having a good, strong bereavement program within your hospital is an important thing. And so for some of our patients, they might struggle with it more. Some of our patients, possibly by that second year, start to feel that kind of the some good days and bad days, kind of I should say, bounce back from that original grief. But just recognizing that as that happens, um, they're going to have good days and bad days, meaning they're going to have days where they're feeling better, and then they're going to have days where it's still very much a struggle. What we can do to help support our patients, and this is, I would say, important to remember when you're providing care to patients that have history of loss, to talk to your patients about it. I mean, sometimes it can just be as simply as, asking, going through their history of their pregnancies with them and asking them about that loss. And that can be, I would say, definitely writing the room with the discussion. Obviously, there's going to be patients that don't want to talk about it at all, and that's okay. There are also going to be patients that might be very triggered by the situation. And just recognizing that how they're feeling about it can impact the bonding with this baby. That they have a history that it's hard for us to we'll never really be able to understand their history. And, if we're able to remember what they've said, or if we're able to remember their patient's baby's name, that's one big piece in being able to provide them support. I have been able to be a nurse for patients that have had loss, and then I've been able to take care of them in their future pregnancies. And I think that connection is amazing, but sometimes we just have to be able to connect with them, even if we did not have that ability. Because this can be a very, very triggering experience to go through another pregnancy, even when that pregnancy is a healthy one. I had a patient once who she had a baby that experienced SIDS, and we called it SIDS, and it was SIDS, but at the same time, it happened while she was breastfeeding her baby, and she had looked down, and the baby was blue, and they were not able to resuscitate the baby. She had fallen asleep while she was feeding. And when we made sure to communicate this. We were a baby-friendly facility, which means everybody talks about breastfeeding all the time. We're supposed to like document it, but it was very much do not talk about it with her, because she expressed that from the beginning, and it was important to recognize that that was a critical piece in her care, to not talk to her about breastfeeding. And I can't imagine going through a loss like that. So it was definitely important for everybody to remember. So some of the cultural differences in perinatal bereavement, we've talked about how it's important to provide that person-centered approach, to know that our diverse families, they can often encounter inadequate support. This can be because somebody feels like they don't understand the person's culture, or it can be because of a bias that the person already has against that patient. It can be because of not recognizing the parental support body, like meaning if you have a patient that's LGBTQ, that they can experience even more disparities in the healthcare system because the healthcare providers don't recognize the partner, and don't recognize the parental group in the way that is critical. I think we already struggle with including the partner within our bereavement care. And then that is just one extra obstacle that we need to overcome. One of the things that I think is really important is, for those that know me and that have ever taken classes with me before, you probably heard me say I am very much anti, we're going to look at this box and we're going to discuss how this group of patients, they believe bereavement care should be this way. This group of patients, they believe bereavement care should be this way. And many of the perinatal bereavement courses that I've looked at and kind of used to try to piece together how I wanted to do this course did it that way, to be quite honest, especially some of the older ones. I don't agree with that. I don't believe that that is a way to learn about culture. They say that nurses need to be culturally competent, and I do think that's very important. But I don't think it's necessarily important for us to memorize, oh, this group of people believe this way, this group of people, because I think sometimes that can contribute to having more of a actually stereotypes, right? I mean, how can you separate memorizing a table of cultural concepts away from stereotypes? So I think it's important to know that there are cultural considerations, and we're going to discuss some of those considerations, but also ask our patients. Never assume that our patients have a specific cultural preference. You know, if you think, for example, the avoidance of patients, if you have in your head, well, this group of people like to grieve silently, are you going to be possibly not providing the care that is so critical to them because you have it in your head that this is the group of people that like to grieve silently, or this is the group of people that like to have their partner make decisions for them? You know, it's important for us to just ask. And I believe in assessment over anything else. So open heart, open mind, and open ears, meaning we ask and we listen to what they say, right? So some of the things like common practices. So we were talking about when do we talk to our patients about bereavement, right? I find that if you are taking care of a patient with a missed miscarriage or a stillbirth, um, a being able to talk to them about um, possibly holding, viewing photographs, that kind of thing in the beginning is um, important. Talking about them in the moment can be very difficult. Um, it's important to recognize that some of our families might find this comforting, especially once we talk to them and normalized it for them. And some of our families might find that it's a I can say that word, but that it's against their religious beliefs or how to care for that body of the baby. You might find this more with, like, I would say, members of the Muslim family or Buddhist faith, but I will also tell you that I have also provided care to um, patients that believe in the Islamic faith that did not feel this way. So again, it's really important to just recognize that there are cultural considerations, but we never assume. So some of the other cultural considerations, and I'd rather discuss them as these are things that we want to talk to our patients about, um, as opposed to assuming that this culture feels this way, right? Talking to them about whether they want to view the baby, and also kind of writing the room and just determining whether they're referring to the loss as a baby. You will notice I do, but not if my patients don't. So I do because of years of doing bereavement care. And knowing I've had patients that had a loss at 15 weeks, I've had patients that had a loss at 17 weeks, and they grieved I as hard. They experienced that loss, and I could not tell you that there was a difference between how they felt about that loss than how a patient that had a 39-week baby felt about that loss. So I will always refer to the baby as a baby unless my patients don't. They may not want to name the baby. Um, some cultures find that to be a sacred piece to name the baby. And if the baby is not born with a heartbeat, they may not want to name the baby. They may not want an autopsy. They may see this as a part of life. So when we look at our patients and how many people have heard staff pass judgment on their patients, and you hear them refer to their patients as, well, they're not even upset. Well, maybe they view this as a part of life. They view this as a part of something that they had no control over. They may grieve very vocally, or they also may feel really uncomfortable expressing grief. And when we watch their video in a second, we're going to discuss how uncomfortable with expressing grief. It's important for us to give them that space to be able to do it and normalize it for them. They may want a baptism or a blessing for their baby. They also may display strong faith in miracles or perinatal grief. So, I have gone to lectures on perinatal bereavement, and I remember I did one. It was an A1 convention, and she was a psychologist. She works actually at the big pediatric hospital in Pennsylvania, CHOP, and she's a very, very busy bereavement coordinator, bereavement therapist. Um, and she discussed how it is important to use the words dead, dying, and death with our patients, and not use terms. And I struggle with this, as you guys have already noticed, I'm sure, of not using terms like passed away, lost, gone, or any other term that is harder to define. She thinks it's very important for our patients to hear the words dead, death, dying, because it finalizes it and it doesn't leave room for wondering, I see her point, but at the same time, I've had patients that we had a 35-week fetal demise and very clear, no fetal heart tones. And I remember I had been called to the unit. I had met them initially when they were first admitted, just briefly, and then I'd been called to the unit because they had many members of their church in the room, and you could hear the praise, the songs of praise and the prayers, and you could hear it three doors down, very vocal. And they prayed for the baby to be born alive. And the staff struggled because they knew the baby had no fetal heart tones. But I think one thing that's important for us to understand is that, again, people experience and grief very differently. And did that hurt them to grieve to pray for that miracle? I can't say that it did. The baby was a fetal demise. And then afterwards, I got to know them, and so did the chaplain that I worked with in bereavement. And they came later to our candlelight service that we would hold. We held one once a year. And they actually spoke at the candlelight service. And I will say, I do think that some of the families, even myself included, I had recently had my miscarriage that year, struggled hearing how they talked about their loss. They talked about how they prayed for the miracle and their baby was born. And the mom, I remember she stood up there and she said, I let myself grieve for one day. I gave myself one day. And then I knew that God didn't want me to continue to grieve. And I just started praying for my pregnancy. And we did find out, they were standing there, they were talking about how they both said, I don't even remember the dad. I remember him saying he knew that this was part of God's plan, and that's how he was going to continue on. And that gave him strength. And for her, that one day, she was a very strong woman. And she was pregnant actually at the time that she had the whole discussion with us. So I think it's important to recognize that how people grieve and how these cultural considerations can play into their grief. We have to allow space for that, and to have that be part of our assessment and how to provide care for them. We're about to take a break before we listen to one of the stories. Does anybody have any feedback from this section?
I have I guess a question, Andra. I don't really, I know that you were saying like in some cases using the word like death, dying, dead is like gives the patients like a sense of like finality and it's not like a questionable phrase, but that just seems very like
Harsh.
well harsh, but yeah, harsh and I don't know, distasteful, I guess. I understand what they're saying. Like, they it's not a questionable term, especially when you have like speakers of other languages who maybe like passed away doesn't translate very well. But just like your baby is dead. That feels a bit, even if you try to say it kindly, I'm so sorry, your baby is dead. It just still doesn't sound very palatable. So, do you have like ways that you have used those terms that don't sound quite so or is that kind of the point is that it sounds the way that it sounds because it is the way that it is and it makes us uncomfortable and we have to deal with that discomfort?
I struggle with it as well, actually. For the same reasons that you said. Um, but have I used that term? I have used things like, well, your baby has died. And I think that sometimes it can be a way. So I will tell you, when I went to her lecture, I had been in bereavement this was 2019. So about 7 years. And I remember sitting there going, I disagree. I disagree. Um, she had I would say, even though she was probably a very experienced bereavement care provider, um, she had interesting, controversial beliefs. She also believed that the cuddle cots shouldn't be used because she said that the finality of seeing their baby, she used the terms even, decompose, was important for them to understand that they had lost their baby. Again, very much struggle with that. So I think that there is a time and place for a patient that is struggling to understand what has happened. I think it's important for us to use things like your baby has no heartbeat, your baby has died. I do think it's important to use the finality terms, kind of depending on the situation.
Okay, I understand.
But I agree with you. It is something I very much struggle with. Okay, we will just take, just because I'm behind on time, we're just going to take about 5 minutes and then I'm going to play one of the first recordings for hearing their stories. I'm going to pause the recording now. Let's see. So it's going to take me a second to get this video. This video is very long. We're only going to watch a section. I have to do a lot of reading for my job after this apparent commercial. PDFs. Can you guys actually see it? Pro extension called speech applying. It's like the voice of the, in as much as people don't. Okay,
Yes.
yes, you can see the video. Perfect. Okay, we're going to watch a fair amount of this because I think they do talk about some very important topics. Like I said, it's 2 hours long, so we can't watch all of it. But I do want to watch this video. We're gonna watch it all the way through until I think it's like about 12 minutes long, just because it's going to talk about several different perspectives. So I think I want to watch this and then we'll have a discussion on it as well. So let's make this a little bit easier for everybody to see. And hopefully I picked the right time. I wrote it down, but hopefully this is it.
Yeah. Thank you for sharing, Tara. And I don't know if anyone else in the panel has any further thoughts.
I'll say, just to say, so this is a 2-hour video talking about breaking the silence of baby loss in the Black community. I think we can probably recognize from their accents that I think this might be from the UK area. I would have loved to have found videos of patients from the United States, but I was not able to. However, I do think that even though it might be from the UK, there's going to be some videos from Canada. You will find that that those differences don't matter really. It crosses country over several. It's experienced similar in both areas. So.
I think as well, in regards to the Black community, it's church where you would go to. But from my experience, it sometimes does more harm than good to me. Yeah, I'm being realistic by saying, well, God knows best. So translating that's saying to me that I wasn't good enough to become a mother. Yeah. And then in regards to it's trauma, because obviously if this may be and you haven't really got the opportunity for your family members who can really be quite transparent and give you the support that you need, it's heartbreaking. So it's like you're grieving for your child, which was your future, yeah, and then other people in your family or friends, they don't, and I think it's so uncomfortable that people just stupid things come out of people's mouths. To be honest, it's for me. But for me, I think sounds for me was my lifeline. Although it was difficult because I was only one of the Black women who there, but I needed that help. Yeah. So I guess what I'm hearing is they're just the people around you. Maybe they wished well, had the best intentions, but they just didn't know what to say. I don't know. Yeah, and it made it worse. Yeah. Thank you for sharing, Carolyn. I think some of the points you raised are some of the things we're going to look at throughout this discussion in terms of what do you say, what is helpful, and the impact that faith can play in someone's loss as well. So thank you for sharing that so far. And I mean, I know, Tara, you touched on the fact that your aunt experienced a loss and you just had no idea until you shared about your own loss. And it does feel like older generations didn't talk or still don't talk so much about loss. It's a lot more difficult for so many different reasons. And I just wonder, and I'm going to direct this question to Carol firstly. Do you think attitudes towards acknowledging and expressing grief are changing? Wow. Are they changing? I think there's progress. Just like right now, today, being able to kind of have these conversations now, being able to be vulnerable and asking for help. I think we've got a long way to go, but I think every family or mother or father who's lost a child, I think it depends, and it's not like one fits all. So I think that everybody's family may be different. So I'm not going to say that it's like all the black community they shut down and like that. I think we have to be fair. I think that in regards to support, I think that needs to still be built, like what you guys are doing today, in regards to acknowledging in terms of the black community who need the support that they require. Because obviously, I work for mental health, and the basically, the statistics is that black women and black men are the ones more than likely to be sectioned, because we don't really talk until it then comes to a point where you haven't got the capacity now, so you've been sectioned. So I think for me, on my journey, I had to I had to ask for help. And even though the people didn't look like me, yeah, and sometimes they didn't understand me, I still had to try to, in regards to my well-being, my grief. There's many a times, and I'm never going to be really honest, that I contemplated suicide because the pain was so kind of like no words could actually express. But I got through that. Yeah, so I think there's a lot of work to be done, but I think that we're on track.
Yeah, thank you. Thank you so much for your honesty, Carol, in sharing that with us. And as you said, things have changed, but there's a lot more to do. I don't know if you have any further thoughts on that, Ryan.
Yes, I do. So going back to the question, have attitudes towards grief changed? I think attitudes have shifted and softened a little with time. Still think there's a general belief that black people should carry themselves and behave in a certain way. Putting on a show of strength and holding it together. Any grieving or showing of emotion should be done privately. The views and opinions about how we're seen by other people is still a deep concern for a lot of people in the black community. Grief is a feeling that people get after suffering from them, and it's a perfectly natural reaction. We need to normalise mourning and grief, irrespective of race, gender, religion, or any other characteristic. We know everybody struggles with the death process. Black people no different in this respect. If we've not been taught to talk about how we feel and develop our emotional intelligence, then we can continue to bury our feelings and sit in difficult places. Thinking like this, how we are about grief in a dedicated space is so important. My wish is that services can adapt and better meet their users. And I just want to go back to something Carol said. You'll hear me say we a lot, and I am talking generally, because not every black person gets the same experience.
Yeah, thank you, Ryan. And yeah, that's a good clarification. And I think what stood out for me there is this need to be strong. And again, that's something that a lot of people relate to, but I think many people in the black community relate to that feeling of needing to be strong, having to carry on and put on a brave face as if you're okay, even when you're not. And I think that that's also something that men experience as well. So, you know, at a time of loss, men may go into doing the more practical side of things, whether that's planning a funeral, whether that's taking care of the family. And I just wanted to ask Tunji, do you feel that's how men manage their grief and show that they're strong? And do you think it's harder for men to grieve? maybe even for Black men in particular, specifically?
Hi. Yeah, thank you. Thanks for asking that. I think there's lots of thoughts that go into my mind in the answer to that question, and I think I'll try and see if I can remember all of them. But the first thing that points out to me is that, especially as a man, let alone a Black man, it's almost as if it's almost as if you haven't got the right to grieve because, well, in a way, I'm speaking of personal experience as well. I'm going to say you haven't got the right to grieve because it hasn't happened to your body or it doesn't happen in your body. Doesn't mean so the bond is not quite the same. Doesn't make sense as a woman. So that's one aspect of it, the fact that it hasn't happened. It has happened to you in the sense of the emotions and it's your partner or whatever the case may be. But in terms of it actually happening physically in your body, it hasn't happened to you. So I feel the next step I feel that men want to do, especially from my experience, is the fact that you want to make things practically okay. So is your partner feeling okay? And in terms of if there is a stillbirth, I guess it's the preparation of things. And it's that whole thing of going into taking care of things more. Does that make sense? The practicality of things. And I feel, yeah, maybe in a way that's their way of, again, only from my personal experience, I feel like I only have a window of grief, a window of sadness. And once that window closes, I haven't got that window anymore. And this is obviously something that I have been working on or would like to work. And it's the fact that having grown up by myself and whatever the case may be, I haven't got time to grieve. I have to do it in this short space of time and move on quickly. And there's other things that Carol has said earlier, and I think Ryan also mentioned about it, and the fact of you being strong. And I think generally as Black people, there's that thing of strength, even from history and all that things. And it's only becoming in the last few years that people understand that no, that strength is something that has been imposed on us and we have accepted it. And so that whole thing of don't let your business out or you have to show your strength, don't let people know you're suffering, that kind of thing. That goes, I feel, again, from my perspective, that's amplified as a Black man. You feel like, okay, I can't let people see me. Well, you're not even thinking about it, you just go into it. I didn't think about it, I just went into it. And I feel like if I had time to sit down or someone sat with me and really dug in, then I'd probably say, yeah, I guess I am grieving. But it was hard for me to grieve. I remember when we were told, I mean, my wife is, we've had, I think, 3 or 4. I mean, we have 2 children now. But we had 2 before the first, and I think 1 before the second child. And I remember the first one, that was the most grueling for me. And it was like, we went to the hospital. And it's the way it was broken down to us as well. It wasn't like, sit down, we're about to tell you something. It was just more like, that's happened kind of thing. And in my head, I rationalize things a lot. I have conversations that haven't quite happened. And in my head, I was saying to the woman, I didn't say it quite, that although you might have experienced this a lot because you're a nurse or a midwife or a kissing bee, this is our first time experiencing this. And so I think after like a few seconds after we were told, I was crying. My wife was crying. I think after maybe a minute, I started crying and I went into practical mode. And that was me. I can't say it was my way of grieving. It was just me of like, okay, I had my window of grief. And now it's just time to, do the practical things and move on. And I guess in a way, the other miscarriages weren't, I don't think I connected to them as much. And that was my way of thinking. It's almost as if you've tripped over once, it really hurts. You trip over the next time, it's like, okay, just get up, just trip over again. You get up. It's almost like, okay, well, I'm going to keep tripping over until I stop tripping over. I'm going to just have to get up. So the other miscarriages weren't, and my wife would say that it felt like I was unavailable emotionally because I just didn't connect. I didn't really connect because it's happened. And so I was just more like, is she okay? Is that done? Is this done? Is she eating? Are we eating? So yeah, I hope I'm answering your question. I just feel like there's that thing of in as much as people don't think it, especially as a man or a Black man or anti-Black man, it's just that thing where you go into it straight away because it's something that is deep rooted in you that you just have to sort things out. And again, like I said earlier, you're the man. It didn't happen to your brother, so how dare you feel like you need to?
Mm. So I was dating this guy, Chris, for years.
Okay. Any thoughts about that video? What did you guys think? Yeah, I agree, Alexis. Alexis says I really appreciated the male perspective. I feel the same way. That's one of the reasons why I wanted to watch it for as long as we did. I think it's important to make sure that we're including the partner. Yeah, it shows that men need support too. I think it's really important to include them from the first moment we can, you know. I don't know if it's on your bereavement checklist, but we used to always have the patient's first name, support person's first name, and then any other support people in the room to write their first names on there. So that way, if the name is David, we're always saying, David, this is what we're talking about. And things like there's a video on that Resolve Through Sharing that talks about how we can bring them in just from simple things like, would you like water too? Just including them. Is there anything that you need? And just including them kind of from that first moment is a way to pull them in as well. I've seen, patients that that the male partner has been doing things, the checklist of things that need to be taken care of. And then I've also seen it where it's very different. The male is, the patient that I'll actually talk about her in a second. Let me get to the next slide and I'll tell her. So admission of a bereaved patient before arrival. So things like making sure that we're considering the room selection. Here we have kind of that tucked away area with the ISO rooms that we use. ISO room, I know sometimes the rooms right in that corner, 12 and 14, using those rooms instead of putting them in an area where they're going to be around hearing babies cry. And I think it is hard for us because we all know, every hospital I've worked at, we've had an area that we tried for, but it's very difficult to keep them completely isolated. That's really hard. But trying to keep that consideration is important. So that patient that I told you about, where she had many pieces of her care. I tell a little bit of her story because of some of the things that happened. So she was the one that had the midwife that had taken her, done her prenatal visit and recorded 120s for the fetal heart tones. And then she was later on admitted. I took care of her in the initial admission and then the second day as well. And I do think that that's important in their care, is trying to keep consistency, trying to keep the same nurse as much as we can, keeping in mind that it can be really hard for that nurse, though. And if it is a patient that's can be emotionally draining for the nurse, we might not want to keep them together. But at the same time, that patient learning new people's names and new relationships with new staff can make it harder for them. So if we can, keeping the same nurses is ideal. So when I admitted her, so you see, in this hospital, we use the purple butterfly, and it's a different purple butterfly, but purple butterflies are pretty well known, especially in the NICU environment, as being associated with perinatal loss. Another symbol you might see is a leaf with a teardrop. That's a symbol that Resolve through Sharing uses to identify a room. So putting that symbol on the outside of the room is a important piece in making sure that anybody that walks into that room is aware before they walk in. And, just as much as you would things like fall risk or an isolation room, it's important for situational awareness for anybody that walks into that room to take care of this patient, to know that in the labor and delivery environment, this is a perinatal loss patient. I had admitted her, and I had gotten the bereavement packet, and I had not put, for us, it was the leaf with the teardrop. I had not put it on the door yet. We were a busy hospital, and I had 2 patients, and I had not put it on the door. It was within the first hour of admission. And what happened was, and you can tell I still feel horrible about this, but the anesthesiologist, who maybe was also not my favorite person in the world, walked into that room before I could stop him. And I was sitting there. We had like pods, so we would typically take care of 2 patients at a time. And I had 2 patients, and I was sitting right outside the room, and he just busted right by me before I could say a single thing to him. And he walked into the room and he said, "So we're having a baby." And I always made sure that I got that leaf for the teardrop, or for this hospital, that purple butterfly on the door every single time after that. The patients, and that's why I wanted to bring them up, was they actually rode with it. Instead of us riding the room with their emotions, they rode the room with his emotions. They said nothing about the fact that they were expecting a stillbirth of a full-term baby. They said not a single thing. They joked with him, and they just jumped right on to whatever his emotions were, and that is how the whole discussion went. You would not have been able to tell from their discussion that there was a loss at all. And the patients, the way that they presented their emotions about it, the woman was very stoic. She expressed very little emotions about any of it. I think she was looking back, I think she was definitely in that shock and numbness period. So we, like I said, we had a pretty good bereavement program. We kind of, when we see that, it's a sign for us to make sure we are reaching out early to give her the resources that she might need, because it's hard to know if this is somebody that is going to, when it hits them, is it going to hit them hard? And how exactly are they going to experience it? The spouse, he was very different than how she expressed it. He was very open with his grief, open with his tears, open with his thoughts. And it's important to recognize that every variation is, we need to, as she was saying in the video, normalize grief and normalize expression of grief and normalize being able to talk about it. I think that's really important. So if we can, talking about the plan of care. So when we're admitting a bereaved patient, this is, for me, one of the most important opportunities to really discuss the expectations of what's going to happen, to really discuss, you know, what is the plan of care? Things like the considerations like the viewing of the baby, pictures, that kind of thing, to talk about. There's going to be some harder pieces to this, and we'll get to that in a second. But making sure that, I think one of the things that can be so, this is a traumatic experience, really, no matter what we do. But being able to have that discussion with our patients about it is going to help at least give them some of the tools to deal with the traumatic part of it. So we'll talk about that more in a second. And part one, there we go. So I think another piece that's important is in the admission, having just keep in mind how to keep that environment calm. This isn't the time when you want all the lights blaring. Not that there's ever a time in labor and delivery that you should have all the lights just blaring and I guess unless there's an emergency and we truly can't see. But keeping that environment as calm as possible is important. This isn't, it is, I do feel that it is very important for orientees to experience providing care for a patient that has a perinatal loss. But at the same time, limiting that, this isn't the time for us to have an orientee that's a nurse and a student and a medical student and we're already going to have our residents. This is the time to try to limit that as much as we can, but at the same time, keeping in mind that we need that exposure for our orientees as well. And knowing that we can, if in that shared decision making, if our patients don't feel comfortable with having more staff or an orientee, we can still sometimes provide that exposure in a different way. So, I've had, have a lot of experience with pictures and doing perinatal bereavement pictures. And so sometimes the staff would call me just for coming down to take the pictures. And I would kind of had an open door, open phone policy of they could call me pretty much anytime I would come if I was in the area. And that we didn't always do the picture. Some of the pictures, a lot of the pictures we try to do in the family's room, and we'll talk about different pictures that we can take. But sometimes we would say, okay, if you're okay, we're going to take your baby to, the other room, and we're going to just take a few more pictures, and we will bring those back to you. And if you can take it in a room that can be better, there are times where it might be harder for them to see, just depending on how the baby looks and how long the loss has been. I had a patient who had fetal hydrops and severe edema. So I believe this was a RH isoimmunization and congenital heart disease and life-limiting condition where they already knew. But the baby was 28 weeks when the baby was lost and severe edema throughout their whole body. And so the breakdown of the baby's skin was significant, probably one of the most severe for being that far along in their pregnancy that I've ever experienced. And that was a time when it would have been very hard to take good pictures, and for the parents to see us taking the pictures. Sometimes that can be harder to watch. And you might have staff, you might have parents that have asked, I want only my baby in the room. And so just preparing them for that and having that discussion, I think, is important. I think that is one of the things that, so Resolve Through Sharing, there's a video that, oh, I wish so much I had the video to be able to show you guys, but it was from a family's perspective, and she was talking about how her baby was born, and her baby had been gone for about a week, and she discussed how she didn't remember when her baby had last moved, and that they didn't really know how long her baby had been gone, but how she wished the staff had told her that that may have happened, that the baby might have been skin had been breaking down well in utero. And she wished she had known. And so she said, and they asked her, they said, well, how would you have wanted them to say it? Like, what words would you have wanted them to say? And she said, well, maybe that the skin was slipping. And I think that is one of those hard conversations to have, but very important. Just like, for example, we will have some pictures of fetal demise. And I do think one of the ways that orientees can be exposed to it is being involved in those pictures if we take the baby out of the room. Even seeing pictures, I think it's important because it can prepare us for those moments that are going to be hard on us too. And so think about how we can prepare our patients for that, how we can prepare them for the fact that their baby is going to have a different color than any baby that they have ever seen or held. That the skin is going to be darker, that it might, look significantly bruised, or might be peeling, that kind of thing, sloping. I think it's important to talk about it. It's hard. Believe me, it's hard. It's hard to even talk about in a class, but I think it's really important to talk about before the baby is born. With limiting staff, I also do think that clustering care when possible. There are times that that's appropriate and there are times that it's not. But if you are, so sometimes, when you have, depending on your loss and what happened, we might do multiple labs on this patient. So that would be an example of times, and I'd say cluster your care. Talk to them about what you're going to do and let them be a part of that shared decision making. But when you're doing your IV, draw the labs. Don't come back in. Don't stick them unnecessarily. I also think it's important to discuss that they can drive their care. They don't need to be in pain if they don't want to be in pain. They don't, and that there's many different ways that we can control their pain, I think it's important for them to know. We need to make sure that we are assessing their behavioral part of their assessment, making sure that we're talking to them about suicidal and homicidal ideations. And that not just the beginning, but also talking to them about things when we get to the discharge part of it as well. Assessing their knowledge. And I will say, I guess, an education level, typically this is part of an assessment. But just keep in mind, you could have a doctoral degree, and it could be in healthcare, and you could be going through this moment, and your education level doesn't mean that you know what's going on. I think just having a discussion with them is important, and assessing as in having them talk to you about what you just told them. And then, as we talked about, don't forget the support person and their assessment of grief. This is a critical piece, not only for figuring out, does the support person have what they need, but also, they're going to be a very important piece in getting through this moment. Assessing the person's, frame of mind and their understanding for the plan of care. I've had patients who have been in their 30s or 40s that have struggled with really being able to grasp what's going on. And I've had patients that were 18, 19 years old that understood more of what they were going through. So it's important to assess that. So some of the communication, I feel like everybody kind of wants this piece the most. It is good to have some things in your head of what you should say. I do kind of say that we should you're going to have a moment where you just freeze. You're just going to freeze. And I think it's important for us to recognize that and know this is something that I say, so things like, I wish this had been different for you. I care about how you're feeling. I wish that this did not turn out this way. I am not actually, and some people disagree with me about this, I'll just tell you, but I also say that saying I'm so sorry for your loss is never a bad thing. I don't agree that some people say that it is. I don't necessarily agree with that. I don't think that that's a bad thing to say. I'm so sorry that you're going through this. I wish this had been different for you. I wish, I think that can open communication lines. I have said, I'm so sorry for your loss. And I think it's also in the delivery of it, letting yourself have that emotion that you're feeling, because this is never a moment that we want for our patients. I think is important. Making sure that we are, following the parent's lead. Like I said, if they're calling the baby by name, call the baby by name, know that baby's name, write that baby's name down. If you forget, just ask and say, I am so sorry. I know you told me her name. You just tell me it again and write it down so I don't ask you. I'm so sorry. And that's what I've said. Also, I've had patients that have not wanted to refer to the baby as a baby. I've had patients that have not wanted to refer to the baby as the baby's name. I think it's important for us to recognize that our patients come from so many different backgrounds. I had a patient who, I came in, and when I met the nurse from before, she told me, she doesn't want to see her baby. She doesn't want to hold her baby. She's refusing it all. And that nurse, when I got report, and I'm sure we've all experienced this, colored the discussion with her opinion and her feelings about the whole thing. And I just remember I had pulled up her chart and I was looking at her background and her birthing history. And I saw that she had gone through a loss 6 months before. So I had a 6-month-old, and she had experienced her loss the same month I had had my 6-month-old. So that's why when I looked at the dates, I was like, that baby that was 6 months ago that she's gone through a loss. She had gone through a 22-week loss 6 months before that, and she was going through another 22-week loss with a baby that was less than 500 grams, which is sometimes the point of when they will try to resuscitate. And I can't imagine how hard that could be. And I think when I learned that, it gave me a perspective that was very different than the nurse that gave me a report before. And when her baby was born with a heartbeat, because it was a free viable birth. And I think that's just to kind of give background for I don't think I said that part, but that was where that nurse was like saying, "Oh, she doesn't want to leave the baby, she doesn't want to hold the baby." But she had done that 6 months before with another baby, and kind of cycling back to what he was saying about with his other miscarriages, how it was hard to connect. I know she wanted, that pregnancy. She fought for it. She disagreed with the doctors on them saying that she was 22 weeks. She said she was 23 weeks and she wanted resuscitation. And at the time, at 22 weeks with a baby that was less than 500 grams, they didn't offer resuscitation because of the feelings of that it's doing more harm than good, and it kind of goes against the principle of do no harm. And once they had discussed that, that's when she really struggled with that moment of, well, I can't hold this baby. She'd been through it 6 months before that. So I think it is important to recognize what background people are coming from, whether it be culture or whether it be their own personal perinatal history. All of that plays a big piece in how we take care of them. Allowing silence. I think that is one piece that is really important and feels really uncomfortable. I'm a nervous talker sometimes too. But being quiet has really helped give my patients power of allowing them the space to stop and express themselves. I think that's important. It can feel like it's a long time, but it can only be sometimes 30 seconds. And the next thing you know, your patient's really telling you or talking about something that is critical in their care. Validating that and reserving judgment, even if I didn't know her history, knowing that's how she wants in her care. That's a piece that she wants in her care of not seeing and holding that baby. That is how we provide care. Things that you should not say. Anytime that you're starting a phrase with "at least," it is never a good way to start the conversation. At least you got to hold your baby alive, or at least I'm saying phrases that are horrible intentionally, but these are phrases that friends and family might say to them. Things like, at least, I had a patient, she was 19 years old, and her parents were, you're going to judge me for the way I'm going to say this, but her parents were horrible. They were going through a divorce and they were arguing in the room with her right there. She had her 14-year-old brother, was probably one of the most supportive ones of the whole family and the sweetest. And she had pulled him out of the house and he was living with her. She was 19 years old. She was one of the strongest women that I've been able to provide care for. And her parents were they were going through this divorce. They were arguing in a room. Her mom I had actually, if she had come back, I would have involved security if I needed to, because my patient did not want her in the room. That is how intense she was when she was there. The father was providing support, and my patient wanted him in the room, was fine with him in the room. And I just remember I had ran into him in the hallway, and he had told me he was going to go back to the house and get some stuff for her. And he said to me that she deserved this. And I said, excuse me? And he said, well, she's so young. She should not have gotten pregnant. She deserves this. And that is one of those moments where I thank God he didn't say it to her. He left and she ended up delivering on her own, which we were the people that provided care for her. And she had delivered before I could get the provider in the room. I delivered her baby, and my orientee was the one that held her hand while she delivered. And it is important to know that sometimes our family and our friends are going to make it worse, right? And so sometimes even talking to our patients about the fact that people might say things that are hurtful, and what can they say if that happens? Giving them the phrase. I talked about how sometimes it's good for us to have a phrase in our head that we can say. Like for me, I tell you, and yes, some people are going to say I shouldn't say this, but I've always said I'm so sorry for your loss, and I do feel like saying that, and saying it genuinely, it's been an icebreaker for me. It's helped open a conversation with them, but giving them the power to also know what to say if somebody says something that's hurtful. Maybe giving them the power to say that it hurts me when you say that, and it doesn't make me feel better. If somebody says it's God's plan or they're in a better place now, you can try again. You're young. I've had patients I had a patient that I called that was 15. And when I called her, she said, everybody keeps telling me that this was better for me, that I lost the baby. And it had permeated her whole entire grieving process. So we need to remember that words have power, and that power can be hurtful and helpful, right? And so I did tell you before, though, you're going to say something that you're going to wish you hadn't said. And I honestly, I don't have specific examples of things that I've said that I wished I hadn't said. I do my best to acknowledge them as soon as I say it. And I do feel that takes away that hurtful power, because it is a way for us to discuss that with our patients and let our patients know that we are going to make mistakes. We are going to say things that we wish we hadn't said. It says, don't ever refer to the baby as it. And that kind of goes back to that whole know the baby's name and their gender, if that's how the patients are discussing them. And refer to the baby as the name Annabelle, as the name Gabriel, as the name that they use, or if they haven't named the baby, maybe as the gender, or however they're referring to it, that's how you refer to the baby. And then if you do mess up, because you might, just immediately apologize. I told you I have forgotten a name before, and I just came back and I said, I'm so sorry. Can you tell me her name again? I know you told me before. I'm going to make sure I write it down so we all know, and just recognizing it. Being careful with phrases, it talks about God's plan. She talked about that as well. Being careful with phrases like angel in heaven. It's one thing to give them a packet that has maybe a poem that discusses the baby as an angel, but to kind of discuss it as it can almost feel dismissive. What do you guys think about these communication discussions? Has anybody experienced either hearing somebody say something that you felt maybe was more hurtful than helpful? Are you guys still there? Can everybody hear me?
We hear you.
Okay. Yeah, I think just knowing, like it says, acknowledge, apologize, and move on is important if you do make a mistake. I'm sorry. I see Alexis says that the kindest phrase I've ever overheard was, "I'm so sorry you're experiencing this difficult time. Do know that your sweet baby only ever knew your love, your warmth, and your consideration." That definitely is a phrase that I think that I can see how that could very much open a conversation, and at least open the door to talking to them. Did the patient receive it well as well? Yeah. Well, the first time I ever heard somebody say, "Don't say the at least" phrases, I felt like it was something that I could really just tuck in my head as, that's so true. Anytime that we're ever saying at least anything, it's like we're minimizing their loss, minimizing their grief. I've heard people say, when it was an earlier loss, I've heard people say that at least it was an earlier loss. And that's heartbreaking to hear, I think it's important to know, and this is really for us as staff that are going to provide care to perinatal bereavement patients, for sure, that we are all in this together. Meaning, if you're not, say you were not assigned the IUFD patient, but you know that your coworker was, check on them. Make sure that they know that you're there too for them. Make sure that they know that they're not alone. I had being in perinatal loss, I had talked to a lot of staff afterwards, and I remember taking care of a patient. I had admitted her, and then I had her the next day. And I was my patient said, she's like, "Well, I want to show you the pictures." And we were looking at the pictures, and there was a lot of pictures that were not the best. And I had told her, I said, "Well, okay, I said, we can take more pictures, and I can see what I can do for changing the pictures, and we'll talk about what pictures can look like." And when I looked at who had taken care of her, I later on, not obviously not immediately, I later on had talked to the nurse, and I found out that it was her first time taking care of a perinatal bereavement patient, the first time taking care of an IUFD. She had been off orientation, I think actually before I got there. I got there as an experienced labor and delivery nurse, though. She was new to labor and delivery, but she had been there before I got there. And but it was her first time taking care of an IUFD. And the charge nurse didn't check in on her at all. And hadn't been there at all for her during, like, sometimes even just during the memories time, the pictures time, that can be the time, if you haven't already checked in on them, to really be there for them, because that can be hard. And so just making sure that we're there, and even just asking them, hey, are you okay? Do you need to talk? Giving them that space is really important. We're going to talk more about support for staff as well. And so just giving yourself grace when you're providing care to them, and whether that grace is giving yourself 5 minutes, or grace for not saying a phrase that maybe wasn't the best phrase to say, that is important. So, okay, we are going to listen to another story. This is shorter than the last one. And this actually we'll discuss, because it is a couple, it'll discuss the man's perspective as well, the spouse's perspective.
I just think people need to realize that there's two people at the end of this, and there's a life lost, and there's a whole life that was supposed to be that's not going to be. And those people have feelings and emotions going everywhere. So the more sensitive people are, they don't need to solve the problem. They just need to be there, right? And to be aware of what's going on, understand, provide the support presence.
Madeline is my daughter and will always be my daughter, and I love her dearly. But I don't know very much about her. I know there are people who have lost children who have never gone on to have a baby themselves that they get to take home and love. And my heart goes out to them. We remember her. She's a part of our family. We talk about her with our other children. We have a cake on her birthday to remember her in a happy way. After she died, I started going into the room and writing in my journal in the rocking chair that I had bought to rock her in. It was a way of feeling close to her. I was, I ate everything I was supposed to eat. I ate things I didn't like because I was supposed to eat them. I did all the things that I was supposed to do. And yet it turned out in the worst possible way. I think that's every parent's worst nightmare, is that their child will die. After she was born, they dressed her in a lovely pair of sleepers and put this beautiful, hand knit cap on her head and brought her to us all wrapped up in a blanket. And she was just the most perfect, beautiful, lovely little baby girl you could ever imagine.
It wasn't just our loss. It was the whole family and friends, close friends, they lost too. So
I remember the day of her funeral, actually, being so surprised that the world had gone.
We've thought this for years. I don't know if I was a good listener before. Maybe someone would say I'm still not, because I like to talk. But I learned to listen, and I learned to listen. At least I learned to let her talk, and I stopped trying to solve the problems that I couldn't. So it was a normal pregnancy in many ways, except the baby wasn't alive. So her breast milk was still coming out, so helping her with that.
And that was unexpectedly painful in an emotional sense. Because your body doesn't know the baby.
Your body doesn't care.
We were still happy to have had as much as with it. It wasn't enough. But we had still had more of her than some people get to have with their children. We know people who have lost children at much earlier stages. I did end up going and finding a counselor, someone to talk to, because I needed that. He was wonderful. I would not be where I am today without him. But there were things I needed help with that even he could not give, because everyone that I could turn to, my mother, my husband, my sister, my friends, they were so sad for me that I at times held back in what I wanted to say because I didn't want to make them more sad. The grief that a dad goes through is no less heart-wrenching than that of the mother. It's just, it's different. Everyone's grief is different. He knew just
by observation things that I needed, just by caring enough to pay attention. And being able to do that, even in spite of his own grief. And those things, her hat and her sleepers and her blanket, are as precious to you as they are to me. They're not just my treasures, they're his treasures, and
I think it's a very individual process to grieve, right? And if you can be patient with each other and with yourself, understand that there's no right or wrong way to grieve.
I think the language is really important. This is somebody's baby. This is their child. This is how they look at that. This is not, I don't care what the medical terminology for a baby that has not yet been born is. That doesn't interest me at all. This is my child. This is my baby. And if you refer to it as something other than that, then that's going to be really hurtful. Every experience we have in life changes us in some way, sometimes in small ways and sometimes in big ways. And this experience has changed who I am. You begin to become a new person a little tiny bit at a time. It's not big steps, it's small steps, and it's over long periods of time that it happens.
So the strongest message I'd give any is that it becomes part of your life, but you learn how to deal with it. But I never lost who I was, and nor did she. And as I talked to you, knows who we were.
I didn't know I could live with that much pain. I thought that it would kill me. I didn't know that I could survive. I have survived what I thought would be the very worst thing that could ever happen to me. And I came out the other side. And that's possible for other people as well.
Because a lot of people deal with this and people don't even know about it, they don't talk about it. But there's a willingness to accept it, go through it, say, it's really dark today, or maybe tomorrow it won't be as dark. You're into something here. You keep walking, you gotta keep somehow moving forward, somehow pushing, somehow getting to the next day and the next. Eventually that day turns into a week and a month and a year, and life gets a bit more normal and you go back to a better place. People at the end of this, and there's a life lost, and there's
any piece of that video that resonated with you guys?
From an IBCLC perspective, when she said she got her milk in, that was hard. I think anticipatory guidance is really good with these patients because if we don't warn them, that their milk is still going to come in, that could be very traumatic.
Agreed.
And I Donna is our labor and delivery lactation consultant, and she will go give them resources and education on what to do when their milk comes in as far as drying it up or donating it if they want. But we just have to let her know that to see the patient.
Well, that, and maybe seeing if we can get those resources available when she's not here too.
Yes, that's true.
Because on the weekends, holidays, that's definitely a very important piece to talk to your patients about. I agree. Yeah, I think being able to discuss with them, about just the expectations. This is most likely, hopefully, the first time they've ever gone through it, may not be. They might have more experiences, and keeping that in mind is important as well. But that there is sometimes, I think, the patients feel like there's something that we're going to be able to, it's going to be an immediate thing, and it's not, right? So talking to them about just what the experience is going to be like, and making sure that they understand that is important. And as we talked about too, about what baby may look like, is difficult, but an important conversation. Discussing memory making, discussing taking pictures and what that can be like, and normalizing all of this for them. So again, I wish I had those videos that Resolve is sharing, but I remember one where she talked about how her nurse held the baby, swaddled the baby, and held the baby in her arms when she brought her to the patient. And when she was holding the baby, she was patting the baby's bottom. And that the patient saw that, and it made it feel okay to hold the baby and care for the baby in that way. It normalized it for her. I think that that's important because this is going to be one of the hardest things for the patients to go through. So talking to them about it and giving them that space so they have time to think about it. You know, it says like if they're not receptive, there's times that even at admission, if they just found out that their baby is lost, that's not a good moment to do all this education. So giving them that space and that time to process is important. Sometimes that time can be, you know, just asking them like, is there anything that you need? Can I get you some water? Can I get you, you know, if it's just anything. I remember I've had a patient that it was their partner and their parents that all came. And the way I opened the door to the discussion was bringing a pitcher of water and cups for every single person, and cups. And I brought in like crackers and whatever I could honestly find from the nutrition room. And I just kind of brought it in and I gave it to everybody. And it might sound odd, but it was a way to really connect with them all, and kind of bring that opportunity to do the education, to discuss what was the plan, you know, to kind of read the room of when it was a good time to have that discussion. So we talked about things like calm environment and caring communication, having that staff situational awareness with the purple butterfly on the wall on the door. So we don't have the anesthesiologist experience like I had. Not to say that it's all anesthesiologists, it could be anybody, but that way there's that situational awareness. Assessment of not only the patient, but also the support person. You know, we're talking a lot about partners, but I have had very, very bereaved grandparents as well, you know. Connecting with that patient and that family is important. But also, I will say, recognizing that even when we talk about the family and the support person, well, I do very much think the support person is a part of that. That is when they're supporting that patient. The patient is still a priority. And when you have hurtful experiences like the divorced family members, the divorced parents, that's not helpful, right? So that was not helping her experience. That was not supportive towards our patient. And so just recognizing that it is important to kind of connect with everybody, but that is only when they're actually being supportive to that patient. So, you know, we sometimes focus on the delivery of the patient, providing them that space. So you guys have hopefully seen when we've given opportunities if there are no fetal heart tones in triage, where you say, would you like to be admitted today, or would you like to go home and come back tomorrow, or something along those lines. Letting them be a part of that shared decision making is really important. Giving them the tools to make that decision, like if there are risks, if we delayed it longer. And just knowing that how they feel about the situation, we don't really ever know how we're going to feel. I'll tell you, when I found out that I had miscarried, had a missed miscarriage, um, I I wanted that. I wanted a DNC immediately. I did. I didn't get one. There was no provider in house that was willing to do it at the time. And I was told to come back. It was several days later. I want to say they discovered it like Tuesday, I think, and I was supposed to come back on Friday if I hadn't delivered on my own. And I did end up needing a DNC. And I remember very strongly feeling that I felt like my pregnancy had fooled me. I felt like I had been tricked by the whole thing. I felt betrayed. It's strange to feel that way and to feel that emotion when you also feel such sadness, but I felt betrayed. And so just knowing that they might want that space and they might not. They might want delivery as soon as possible as well. So we're going to talk about memory making and some of the pieces with that. Let's see. I think I was going to originally do a break. If you guys don't mind, I'm just going to double check how my time is going. Being that this is the first time to teach this, I wasn't exactly sure how timing wise it was going to go. Do you guys need a break? I feel like with the videos, if you needed a break, you might be taking one then too. Are you guys okay if I don't have a break? But if you want a break, is okay. I see Kay says she's good. If you want a break, just say it, but I'm fine. So a lot of times it's for me to be able to run to the restroom. So I'm going to go ahead and continue then. Okay. Thank you guys. So for memory making, talking to them about seeing the baby, holding the baby, there is, when we've looked at literature, research that has actually talked to bereaved families, bereaved patients, some of the feedback that we've gotten over the last several decades that has really driven how we do bereavement care is that patients felt that they were not given the opportunity to see their baby or hold their baby or express their grief, that was not normalized for them. There was a video that Resolve through Sharing where, again, one of the ones I wish I had, where she talked about how she had I want to say 37-week loss, and she was the patient that talked about the skin slipping and how she wished she had known that was how her baby was going to look. And she talked about how she held her, and Lydia, I think was her name. Lydia was swaddled and she was holding Lydia in her arms, and how she never opened the blankets. She never opened the blankets to see what Lydia's feet looked like, and how she was very sad because she never opened the blankets, and how she wished somebody had said to her, would you like to open the blankets? Would you like to look at her feet? And, I think about how that's how when we have experienced having babies, how that's one of the things that we do as parents sometimes is a way of connection. And that's something that we can do for our patients as well. One of the things, and one of the things I've said to my patients is when I see traits, like I see that the baby has the mom's lips or the dad's nose, I've said that. And I know it's not easy to say, but at the same time, it can be hard for them to see the baby, but that helps normalize being able to spend time with the baby. We will talk a little bit about some of the memory making and why that can be important. Some bereaved families have expressed that being able to spend time with their baby, even in this situation when the baby has already passed away, that helps them make memories and attach to those memories. It's a complicated grieving process. There's nothing we're going to be able to do about the fact that that's a very unchangeable fact in perinatal bereavement. It's going to be complicated. What we can try to do is decrease our impact on that complication, meaning that's where we keep in mind the things that we shouldn't say, because when we say things that are hurtful, that can make it worse. It's also where we keep in mind normalizing spending time and allowing them that space. They don't know that is normal in perinatal bereavement. And so telling them that, we can keep your baby in the room. We can take pictures. You can hold your baby. So I had this one patient, and I had been doing bereavement care for several years by this point. I had experienced my own losses at this time even. But I remember something that changed kind of everything that I did in bereavement happened. And we'll actually discuss this book in a little bit, but I'm going to jump ahead and talk about it now. There's a book called Ghost Belly, and I have a picture of the book later, but it is about a woman who experienced loss. And she had a delivery that is kind of the what, if you had to picture the nightmare delivery, it's that 41 weeks. She wanted to deliver at home with a midwife, and had done this before with her first baby and wanted to do it again, and was really failed by that midwife and many things that happened. And she her baby's name was Zeus. And that was the nickname that they had given him, because they didn't know the gender when she was pregnant, and her son had nicknamed him Zeus. And she decided that was the baby's name after the baby was born. And she did everything she could to spend time with her baby, to even to the point of when the baby was given to the funeral home. Her brother had passed away during this whole time as well. And because of his funeral, they had decided that they were not going to bury her baby and do the baby's funeral, I think, until like 2 weeks or a month later. It was a significant amount of time. And the funeral home director was very caring in his ability to allow her to come and spend time with Zeus. And so she would come and she would spend time with her baby in the funeral home. And he even allowed her to, she would take the body of Zeus and she would carry the body of Zeus around, and she spent time with her baby in that 2-week period. And what she discussed was how she was grieving as a parent, but didn't have the memories to attach to and how that hole was irreparable. And that by being able to spend time with him, it was a way to attach to these memories. And that changed everything about how I took care of my patients. I began to realize that spending time with their baby was one, to normalize it for them, but two, was one of the most important pieces. This was before cuddle cots actually were a thing. Cuddle cot, the company and the brand and everything, it was not a thing in bereavement care. That's actually changed a lot in the last, I've been in bereavement for 13 years. And it's changed a lot, thankfully, in the last decade or two. And even longer when I talk to patients that have had losses in like the 90s. So that was not a thing. I realized, though, that we needed to facilitate being able to keep that baby in the room. We had policies back in the day. Hospitals had policies where you transfer the baby at 6 hours, or once the baby went down to the morgue, you couldn't bring the baby back up. And we had these very specific rules and regulations that had been in place that were not right and that did not facilitate that memory making. And when I read that book, it just opened my eyes. And we talked about memory making before this, but it really opened my eyes. I see Kirby's question that one of our cuddle cots is working. Only one is working and it leaks. How do we go about getting that fixed or replaced? I think I would say probably I want to say Biomed should be involved in that.
I don't know if Biomed is involved because I think they were like donated to us as a gift. I don't think they were like something that we purchased because I don't think they have the hospital sticker on them. I'm not totally sure. I do believe they were donated as a gift, but only one of them works, and the one that does work leaks, which I feel like obviously we don't want that water just going places.
Yeah, agreed. Absolutely. I think that's actually pretty normal that there have been a lot of support groups and groups that have worked with bereaved families that have done donations of cuddle cots. We could possibly work on looking at contacting the company about it, working through Paul for it. But the problem is if we don't have a contract, that might be difficult. The other option is looking to see if we can get another donation or looking to see if we can purchase. I would say purchase would probably be the best way of fixing the problem. Purchasing another cuddle cot. And there are one of the things I think I've mentioned that I struggle with when it comes to bereavement care is cost. But there are companies that have companies and groups, nonprofits that have ways for us to get it for free. So that might be something we have to look at as I think if you're on this group, then that means that you're probably interested in bereavement care and maybe want to join. I think we need a strong bereavement committee within downtown within our unit practice council. And I know Lainey is very involved in bereavement. I've heard Becky Dean as well. So I think making sure that we, if you are interested in it, that we are involved within this bereavement committee and work towards getting things like a new cuddle cot or work with a nonprofit to get another donation. So to kind of go back to what we used to do, we used to take basically just bags of ice and wrap them in Chuck's pads to keep it in case it started to leak or just the condensation. And then we would actually tuck it underneath a blanket or even not wrap it in tuck it underneath something. So that way, obviously a Chuck's pad is not pleasing to the eye. we would put the baby in a cot and have that in there. There's many different ways that you can do it, and there's not, some things are harder than others. I am not a person that believes, I've had people say, well, you should always have things like always have the warmer out of the room, or always have, you don't want any cradles in the room. I don't necessarily agree or disagree. I think it's all in how you perceive it. I've had patients tell me when I've asked them, actually, because like I said, I've actually talked to some patients for years with our candlelight service. So I kept in contact with people over a 5-year period. And I've had people tell me that they were never upset about the warmer being in the room, that they had had a baby before and they expected the warmer to be in the room. So there's things that we have in our minds that are going to be important for our care, and they're not always. So if we're keeping the baby in the room and we want to keep the baby slightly cool, so it keeps that decompensation from happening, we might think that it's not good for our patients to have that ice bag in the room, but it doesn't necessarily change their experience. Obviously, there's going to be some people that might feel differently, though. I think normalizing it, though, for them to be able to spend time. So after I read Ghost Belly, I had a patient who that's how I educated her. From the moment she came in, I had a whole talk with her about she's able to spend time with her baby. She can keep her baby in the room. And she kept her little one. Her name was Savannah. The baby's name was Savannah. She kept Savannah in the room all the way up until she discharged. When she discharged, she kissed her baby on the forehead, and we discharged her, and then we took her baby down. And I realized how important that can be, normalizing it for them in that moment. So yes, normalize an abnormal situation. We've talked about referring to the baby by name, encouraging the parents to hold baby, see baby, but again, recognize that you might have parents that either are that is going to increase their distress due to their cultural considerations or their own emotions. Knowing that, empowering them to, if that's how they feel, to allow that to be part of the process, you know what I mean? Pictures have power. So kind of going back to the patient that I talked about, actually, she's the same patient that her little one's name was Savannah. The nurse that took care of her was the nurse that was really new. Charge nurse didn't help her. And that next day when I came into the room, I said, she said, oh, I want to show you the pictures. And just know, always, you can actually ask them. A lot of times I've had so many patients that want to show you, they want to show off their baby, just like anybody that has a baby, they want to show off their baby. And so asking them if they want to show you the pictures is okay. It's okay to have that discussion, especially, you'll know the connection you have with your patients. She told me, I want to show you the pictures. So we were looking through them, and this is when I saw that they were not the best pictures. And so I have a friend, she's also a nurse, and she says, and she will probably say this until she's no longer a nursing, until she retires, maybe even after that. She says, if I had a loss, I would want every single picture. And I said, I get that. I understand that that's how you feel, but you also need to recognize you're a nurse, and you're a nurse with experience in perinatal bereavement. And not everybody has that. I think it's important for us to remember the pictures, they really do have power. So we're looking through these pictures, right, of her baby, and we're about to go to the pictures. And knowing that they do have power. There are some pictures we can see, and you may not even be involved in this baby's care, but it moves you, right? So one of the pictures was really it was like a picture of what you would see of a baby in a casket. She was flat, head like this, and literally they had put her arms in a cross just like this in the crib. That is an example of a picture that has power, and a picture that if I had, I've taken pictures where I'm like, oh, that's not the picture to give to my patient. That is important for us to recognize. And as I'm going through it with my patient, and we saw that picture, and I said, oh, and I don't remember, I may not said, oh, I may have just been completely quiet, to be honest. And she said to me, yes, this one hurts me. This one hurts me a lot. And my heart broke for her. And I asked her, I said, well, we'd already talked about how I was going to take some of them and I was going to reprint them. So there are ways that we can make some of the hardest pictures to see and still give them a memory. Being able to do pictures in black and white, we see several of these pictures, especially if the baby has discoloration. If we have really advanced technology, we're able to change the coloring of the picture. That can be definitely helpful. But if we don't have that ability, black and white or sepia. Sepia is this picture right here is an example of sepia. Can be very helpful. So I had taken the pictures that she had and I redid them in black and white and sepia. And I also took other pictures. And I'd asked her beforehand when we looked at that picture that was so not the way I would ever take a picture. I said, would you like me to take this one out? And because she had already seen it, she said, no, I can't. I can't not have one picture of my baby. But she wouldn't have felt that way if she had not seen, right? And so if my patient tells me, of course, if my patient says, I want every single picture, I will say, of course. I might separate the pictures and give them to them. We would always take our pictures, we'd print them, and we would put them in an envelope. And that went into the memory box, and it was labeled very clearly, pictures. Because just because our patients are requesting it, they may not be ready or wanting to see those pictures emotionally. You can take pictures of pretty much any gestational age. So this picture right here is very, very early loss. And I had one of the hardest times that I ever took pictures. Baby was 14 weeks. It was a 14-week loss, and she had history of a gastric bypass, and this was her second pregnancy after a gastric bypass. And just for your knowledge, the risk of an IUFD is increased after a gastric bypass, and they typically ask the patient to not get pregnant for a specific period of time. Her first pregnancy was successful within that window. It was a healthy pregnancy. Her second pregnancy was still within that window, and she experienced significant complications. She had lost some of her bowel from basically necrotizing infection within her bowel. And while they had her intubated and doing that surgery, they had discovered that the baby was blood lost as well. And they had taken the baby out at that point in time. I think she had a history of a C-section. So they had both the OB provider and the general surgeon, and the surgery was a very long surgery, very complicated. And she had been intubated for about a week after the surgery. And when she woke up, they had told her about the loss, and she had said that she wanted pictures. And so they actually argued with her and said, no, you can't have pictures. You lost the baby a week ago. And I got pulled into it from one of she was a nurse, but she was the nurse that was kind of like called anytime there was a patient communication issue. And she had pulled me in, and I said, okay, I will do my best. And I went down. I went down to the pathology area because this was less than 20 weeks. So less than 20 weeks typically will go to pathology, and that's actually in our policy as well. And then over 20 weeks goes to the morgue. And I went down to pathology, and the woman that met me down there, I went down with a friend of mine, was able to come down with me, and I'm very grateful to her to this day because it was an emotionally difficult task. And the pathologist, or the pathologist assistant, I don't believe she was the pathologist, probably not one of my least favorite people in my memory. She came up to me, she put a Chuck's pad down, she put a measuring tape down. She took the baby was in formaldehyde. She took the container, it was like container similar to like what we put placentas in. She took the top off. She dumped the baby out on the Chuck's pad, put the measuring tape down, and said, there you go. I don't know what kind of pictures you can do, and walked out of the room. And like I said, least favorite person ever. And I was very grateful for the nurse that came down with me. We took pictures. We were able to get pictures in this situation. The baby had been gone for a week. And pictures similar to this, we took pictures of the feet. We took pictures of the hands. We used blankets to hide parts to be able to take certain pictures. We did take a picture of part of the profile, but with a hat and a blanket. And we put them in an envelope, and we went up to the patient's, or I went, this part I did by myself, but I went up to the patient's room, and I gave her the memory box, and I told her about the pictures, and she wasn't ready to look at them, but she was very grateful to have them. I stayed connected with her for her subsequent pregnancies and through the candlelight service as well. And just being able to provide those memories was an important piece for her grief. Being able to do pictures where you can concentrate on the parents and their expression of love for their babies. You know, the picture of her giving this baby a kiss, the picture of both of them holding their baby together. The little one, Savannah, and I had a picture where I just had her hand and her little baby's hand in her hand. And, you know, pictures like this one. If the baby is born alive, being able to try to take pictures during that time can be really, really precious moments. You know, if your patients are holding their baby, talking to them about it and saying, would you like a picture of this? That can be so important to be able to preserve that memory. Also knowing that, so we have resources, you know, there is something called Now I Lay Me Down to Sleep. I'm going to see if I can pull it up for a second. Just give me a sec to Google, sorry. So Now I Lay Me Down to Sleep is a nonprofit organization. You can, as a medical provider, you can come in here and request services. They have been around for a long time. I don't know why it's not. Maybe it is working. I'm just being impatient. They've been around for a long time. You can see, though, that they do have limitations on their hours and gestational weeks. So 7 a.m. to 10 p.m. and then guideline of about 22 weeks. But one of the things that they do is that If they don't have the ability to come, they have retouching options available. So that's something else that we can talk to our family about, and give them this contact information so they can take their pictures and send it in to Now I Lay Me Down to Sleep, and they can make perfection out of our pictures. So that's a resource that's really important to talk to them about as well. I've gotten the opportunity to take a class with them for photography, and they can do some amazing retouching with it. So definitely connecting them to that. There are so many resources that are from nonprofits. There is another one that I always loved called Molly's Bears. So Molly's Bears is a organization that works as a nonprofit as well, that the families can come in here and they can, it says order. Now I'm curious because it used to be completely free, so I'm not sure if it still is. So we might want to look at that to see just exactly what the service is now. It's been around for a really long time. So what they do is they send a bear that actually weighs the same as the bear or as the baby. So, we, for our memory making, take weights and measurements. Even if it's under, sometimes under 20 weeks, that's not part of the documentation. Even if it isn't part of the documentation, always have the weight and measurements of the baby. That way, that can be part of their memory. You can give them a card with the weight. You can give them a card with the measurements. And so Molly's Bear sends them a bear that actually weighs the same as the baby that was born. So a friend of mine, he's a neonatal nurse practitioner now, but he used to be a NICU nurse before that. And he was a pediatric nurse before that. And he lost a baby when his wife was 28 weeks pregnant. And they got a Molly Bear, and he actually used to come and talk at our bereavement service. And Molly, the bear that of his son that he lost, is in every single family picture that they take to this day. And they lost him 12 years ago. Every picture, his son, the moment his son that he has now was born, they took a picture with him and that bear. And so connecting them to things like that, to being able to have, a bear that weighs the same as their baby that they lost. The thing that's heartbreaking is the idea of just going home with empty arms. So if we can fill those arms with memories, that doesn't take away the loss, but it might help, right? So things that we can do, taking pictures prior to birth, during the labor process, that might be a memory that they're able to look at once the baby is born, in the arms of the parents, family members, family portraits. We talked about the weights and measurements. Posing with wedding rings, a picture with the baby and both the parents and their wedding rings in their baby's hand. Giving it back. That is one thing that they talk about a lot in Resolve Through Sharing, of the rituals that are important, and just letting them be parents and giving them that parent moment, like a bath, or telling them if there's an outfit that you wanted to take your baby home, and if you want to bring that in, we can take pictures with that. If there is, maybe it was baby shoes or a blanket that was given to them, taking pictures with it. Close-ups of, the baby's hands and feet. Hands and feet are oftentimes pictures that you can get even in some of the worst situations. Blankets and outfits, and then even things like the little cradles that we can get now. can really help with making pictures that can be something that I've had patients that have kept one area of their house that's dedicated to their baby that they lost. And if we can give them a picture that they can look at and not experience more trauma, but maybe experience that connection to it, that's what we're giving them. So there's another thing that's kind of come out. I wouldn't say it's newer. You see, 2014. I will tell you, I don't remember it being discussed as much when I was in doing a lot of bereavement photography. So I would say it's a little bit newer now, is doing water immersion photography. I've also seen people do it with like normal singing as well. But this can especially be helpful when we have a really early loss or a loss with significant trauma. This can, if I had known about this with the 14-week baby, perhaps I would have been able to. The baby had gone through some significant trauma, so it would have been still harder. But it can definitely help. So looking at some of these pictures, you can see that these are very early losses. But these pictures are amazing. I love this picture where it looks like probably the parents is what I'm guessing are holding the baby. You're able to capture a moment that would not have been possible. When I look at these water immersion pictures, I honestly think, oh, I wish I'd known about this beforehand. How many of you guys have gotten the opportunity to do water immersion photography like this? Has anybody ever?
How many of us what? I didn't hear the full question.
Have you guys ever gotten the opportunity to do water immersion photography?
I have seen some of the water immersion photography pictures in the bereavement room, but I don't know that we actually have the stuff to do it. As far as like, I don't know that we have a clear basin.
Okay.
I mean, other than a graduated cylinder, which is not the memory we want to capture. I don't know that we actually have a thing to do it. And then does the camera have to be submerged, or the camera's just on the outside of the container?
Outside of the container.
I did see a class offered on it, not like from the hospital. It was like honestly through like TikTok or something. And the photographer seemed really great, but like you said, a huge barrier was the cost of it.
Interesting. Like the cost of doing it?
No, like it was a woman who specialized in like bereavement photography, and she taught a class on how to do bereavement photography and water immersion photography, and I think she taught it to healthcare providers or other photographers, and it was a very expensive class.
Got it.
It wasn't, like I said, this was not anything that I saw on like through work. It was like I was scrolling on TikTok one day and I saw it and I followed her link to the class, and it was like $600 or something.
Yeah, it goes back to how expensive this stuff is.
Yes. So I was like, yeah, that seems really great, but is quite expensive. And I feel like I'm not the best at taking the photos. Like I really try to recreate the photos that I've seen that other people have taken that I think are really like nice and tasteful. But I do have a hard time sometimes. Like I never know if I should give them to the parents in color or not, because like if the baby's face is like almost like gray or black, it seems really hard to give them a photo, because like these babies that I'm seeing on this screen, yes, I do see that some of them are bruised and such, and obviously they aren't fully developed, but almost always tend to give the parents the photo in black and white. Or I try both, and then I give them one, and I'll maybe put the other one in like the memory box.
I think that's okay. I mean, I think it is. I actually usually do the same. I usually do color and black and white, unless the color is significantly hurtful. One thing that what's hard is we don't have the ability to, because I've seen what you guys have as your resources, and in the military we ran into the same problem. So the bereavement class that I got to take, they actually gave us this disc, and it was a long time. I mean, I guess 2019, but that's what, 5 years ago now. Where they gave me a disc where I could use it to retouch photos. But in the military, I was not allowed to just put a disc with software program on my computer. And I definitely was not allowed to download patients' pictures onto my computer. So there's just things that really can be hard in our care of our patients. Now, I do think, and I'll have to like look at this again, because we did find a way to do Now I Lay Me Down to Sleep ourselves, where we would take the pictures ourselves and load it up to Now I Lay Me Down to Sleep, and they would retouch it. I do think that there's permissions that you have to get from your patient, though, to do that. So I can look in more into those resources. But yeah, I think that is, you bring up some really good points. I'm actually making a list, Kirby, of things that we as a organization need to look at investing a little bit more in, because a lot of times this is like stuff that's donated, but that shouldn't always have to be donations. That was one thing I had struggled with, being the chair, was getting people to pay for the memory boxes. So much to the point that one time I just went on Amazon and bought memory boxes myself, just because I couldn't get anybody to actually say that they would pay the bill. And that was really hard. You know, they said the pastoral services are going to pay it. And then pastoral services said, no, you know, it should be labor and delivery. And it was hard, because it should just be part of our care. It should be, to me, it's as important as making sure our patients have linens. It's as important as making sure our patients have, you know, appropriate bed. It's critical in their care. So I struggle with.
Thankfully, we do have a ton of like donations. Like, I have not yet ran into a situation where we didn't have a box or we didn't have like blankets. Like, our bereavement room is pretty well supplied. I think it's just more of like sometimes, like, you know, like I said, the cuddle cot is leaking, or, you know, I don't expect our unit to have a professional Nikon camera, but like we have a little bit dated camera that sometimes doesn't work on the printer. And I do think that we have access to Now I Lay Me Down to Sleep, but from what I understand, it's just that we call them if the parent agrees to it. And they tell us like, okay, a photographer can come today or someone can come tomorrow. And they come. I don't think it's anything that like we don't like upload the photos or anything to a website or anything like that I know of.
There is a way. I know, I'd have to go back and look, but I know at least definitely in 2020 and 2021 for sure there was a way, but they were still coming in house. It was just like you could also do that. I know the parents can definitely request the retouch that we saw on the website still, but I'm pretty sure there's also a way for us to do it. But I can look into it more. One thing, somebody, have you seen Now I Lay Me Down to Sleep actually come?
I have not seen them actually come. The one time that I've called them, I had a 37-week IUFD, and I called them, and she was a primate, so it was essentially going to be like a ground up induction. And I kind of said, you know, I don't think she'll be delivering today. And they said, okay, great. We don't have anyone who can come today, but someone can come tomorrow. And when I touched base with the patient later, because she ended up going to like the MICU and then she came back down, they did come. I wasn't there to see them come. But I did have a question, Andra, about like photos. I feel like in nursing school, and I guess this is why I want more clarification. I feel like in nursing school, they're like, take the pictures, even if the patient says that they don't want them, take the pictures because they might come back and decide they want them. But in our bereavement room, we have like a photo release paper that the parent has to sign, I guess, for us to be able to take pictures. So my question is like, when they like vehemently decline photos, should we still take photos or should we just not take any photos? And like, can we only take photos if they sign the release? And
that's a heavily debated topic. So we can only take photos if they sign the release. That's my personal opinion. However, what I also tell my parents, what I've told my patients is that we can take photos and hold them for them, but that would be something that as a bereavement committee, we would decide that we can, and this is the process and this is how we do it. So we would do that. We would say that even part of that photography release, that if they didn't want the pictures, we could always take them, put them in an envelope and hold them for maybe we actually told them a year. To be honest, like I said, I was bereavement coordinator. I held on to them until I turned over, and then I don't know if they continued the process, but I only had it happen with 2 patients in 7 years though. But so it wasn't super often. But I actually don't, I've heard the same. The Naval Hospital, they used to do the same thing. They used to say the same thing. But we already talked about cultural considerations of some patients might feel that it's desecration of the baby's body. So that some patients very much strongly believe in not taking pictures. And I've had patients, I had a patient who she wanted nothing to do with that delivery. We held a sheet up for her so she couldn't see anything. She wanted us not to refer to the baby as a baby. She wanted it to be as medical as possible. She was actually requesting for the baby for a C-section. My provider at the time pretty much heavily said that they're not willing to take that risk for a non-viable baby. The baby had already passed. It was IUFD at 26 weeks. I feel conflicted about that, but that was, I'm not the provider. So, I would never take pictures of that baby in that situation. Do you know what I mean? Like, I remember how vehemently she felt about not wanting any memories. I mean, do I think that they might regret it? Maybe. But I think it's more important to provide the care that they're asking for. Does anybody else feel differently? Or have anything else to say about that?
no, I mean, I think that's pretty spot on. Like, I know that there are several cultures that believe, like, if they keep anything of the babies or like a blanket or anything, they believe like the baby will not like pass on to whatever, God's spiritual afterlife that they believe in. Um, so yeah, I mean, of course, like we don't want to disrespect their grieving process and how they view it. So I was just wondering kind of like I guess maybe what you said, like if our bereavement committee comes up with something that's along the lines of like, hey, you don't want to see these photos now, but would you like us to take them and they'll be available for you in up to 1 year if you decide, kind of thing, in which case they would need to sign the release, although we don't necessarily give them the photos right that moment, like you said.
Right. Yeah. Yeah, and that might be a discussion for our committee. So molds. This is something I don't think we have the ability. I haven't seen when I was talking to Lainey. I don't know if we have the right supplies for it yet. So that might be something that we need to look into. Molds can be amazing memories. One of the videos from the result they're sharing, they did a hand mold, and the mom talks about how she had SIDS loss of a little boy who was about a few weeks old, and she remembered holding his little hand, having his fingers, his hand wrapped around her finger, and so she would go up and hold the hand of the baby's mold at the hand, and that as she talks about how precious of a memory that was. There has been if you guys know me, probably know I'm a big labor and delivery nurses rock fan from the Facebook group. And yes, I'm old, I'm still on Facebook. But anyways, there's been a lot of talk about doing the face molds. I don't know if you guys have gotten the opportunity to see this, but this is a face mold. And I'm going to see if I can pull it up over on my other screen. They talk about how they did it in the post. So they used a disposable pie pan. They mixed the mold material in a bowl, and then they put it in their pie pan. They used some cold water, and they swaddled the baby and then held the baby down so they could get the mold of her face. When they lifted it up, they poured plaster of Paris in it and let it sit overnight. And so that's how they were able to do a face mold. Obviously, this would be something that you talk to the parents about, because that could be something that they might feel they may not want, especially when it comes to like the feelings of desecration of the baby's body. That's a pretty more invasive type of memory making, but it also could be a very special memory for the family. These are just some examples of memory boxes and memento boxes. I can't remember. I actually ran down and looked what group you guys use. This one is like the Resolve Through Sharing box. And obviously all of these, they typically come with a cost. There are many different types of memory boxes or memento boxes. It doesn't really matter. You can find ways of making memories in so many ways. I had a patient who had a loss in the 90s. She wasn't my patient, actually. She was one of the ones that came to the candlelight service. And she talked about having a loss where maybe it wasn't nice, may have been like the early 2000s, but it was pretty significant loss for her. Her husband was active duty military. He was deployed at the time that she had the loss. Baby was about 27 weeks, and that was the only pregnancy that got that far for her. And she had delivered out in town in Jacksonville and had no memories, no mementos, nothing was given to her to take home, no pictures were taken, nothing. She had nothing to remember it by other than the traumatic memories of the delivery. And that was extremely hard for her. So much to the point that, at the perinatal loss or the bereavement service, we would do the service, the candlelight service, and then we would, our committee opted to like provide snacks and like just give them an opportunity for all the families to come together. And we would disperse the people within the bereavement committee to kind of sit at the different tables. And our chaplain came and was involved in that as well. And she was probably one of the most vocal ones that was there. And it was one of the first, she said it was one of the first opportunities she really had to talk about it. So it still struck her 20 years later. And I remember her husband, I said he was deployed when it happened. He he grieved very vocally at that candlelight service. And when we were talking to him, it was really hard on him because he wasn't there. And then there was nothing that he could attach his grief to because there was no mementos, no memories, no pictures, nothing. So to go through something as hard as that, and she described her birth, it sounded terribly traumatic. Prenatal or preterm labor, preeclampsia at the same time, and bleeding and delivery. That's what she went through. And to go through all of that and to have those memories and not to have memory of a footprint, a handprint, a picture, a blanket, a memory box, or even sometimes if just writing a card to your patient. And we would do cards where we would have anybody that had been involved in their care, we would have them sign it. We would put it in an envelope and put it in that memory box too. And then these are like the Bridget's cradles that you can use. And there's also, giving them, sometimes they have like little rings that you can do as mementos. We would take pictures with the rings and we would put them in the box. It's really just about anything that keeps them from going home with empty arms. Because they are, right? And so even if it's just memory that we're able to try to make, try to facilitate, try to give them, that's something. So we talked about the cooling cots. Ice, if we don't have a cooling cot, is also a potential option. If we, like I said, taking the ice and then wrapping it up in a blanket can make it a little bit, a blanket first with something to absorb it, and then a blanket can help facilitate slowing down the process, but at the same time, not being as hard of a thing for them to see still. And also knowing, like, even if you don't have the cooling cot, just like I didn't have the cooling cot with the woman with her baby Savannah, it didn't matter. I mean, yes, the baby, it was going to decompensate a little bit, but it really didn't matter. It still gave her the opportunity to spend time with her baby. There's no restriction on this amount of time versus this amount of time if you don't have a cooling cot. And this is that book that I told you guys about, Ghost Belly. It is a hard read, but it's a good read. It really just helps you to see somebody else's perspective. So kind of some of the delivery priorities, making sure that they know that their pain, if they don't want to be in pain, we don't want them in pain. I will advocate to the nth degree with any anesthesia provider that doesn't want to give them an epidural or doesn't want to give them whatever pain relief they're asking for. But I am a big believer that if they don't want to be in pain, we don't want them in pain. Whatever that means. I've done PCAs for bereaved patients that weren't full term. I've done PRN pain medications. For full term patients, an epidural can be as important of a relief as it is for a laboring patient. I've also had patients that have said that they wanted to feel the pain, and when I asked them and talked to them about it, I found that for them, that was going to be part of the memory. That's what they had always wanted. They wanted a natural delivery, and they didn't want any different just because they had already lost their baby. So discussing that with them, we don't have to force what we think they should have on them. Listening to them is really important. We've talked about how connecting to our patients, and I think I've a little grammar error there, but it's really important being in the moment with them. expressing grief for them is important. Do remember that once the spotlight has turned to you, so it's sometimes I hear people talk about, do I share? Is that good or bad? I don't think it's necessarily a bad thing. I don't think it's bad to say, if you've been through a loss, to say, I don't know what you're feeling. I'm not in your shoes. I've been through a loss before, but every loss is so different. I don't know what you're feeling. Once you've taken that spotlight away from them, right? That's where we have misstepped. So if we are, even whether it's the grieving part, whether it's expressing something that you've been through too, that is okay to a certain degree. Sometimes it helps open the door. I had a patient who told me, because I actually took care of her a month after my loss, I had said to her, I have been through a loss before, but I don't know what you're going through. Please know that you can talk to me, and she did tell me, she said, I know that you've been there, and it just helped me feel like I could really talk to you. And so sometimes it can help open a door. But once the spotlight is on you, it is too much. You need to turn that spotlight back on them. It focuses them. Doing that, I said, silence is golden. It is hard. It is hard sometimes. But if you don't give them that space to talk, they're not going to talk. And you may have missed a very critical opportunity to hear what they're feeling. We talked about how supporting the family is important. It is critical for us to know that every piece of this grieving process we play into it, right? We are the person that they're going to remember. And, we talk about how it's a complicated grieving process, but one of the things that I think is important to remember, no matter what your patient is telling you, there is a chance, probably, I'd say, and without trying to make a generalization, a good chance that they're going to feel or experience some guilt during this whole process. And we have to be really careful about what we say that can contribute to it. I told you that I've been through a loss, and I know a lot of things about bereavement. I know a lot of things about miscarriage. I've been in this for a long time, but I will still tell you that there's a run that I went on right before I lost my baby. And the logical part of me knows that I played no part in my miscarriage. And the very illogical part of me believed that and believes that for years. I have a coworker who experienced a loss at 26 weeks. And as much as she knows about bereavement care and about labor and delivery, you will never convince her that it wasn't the plane ride that caused her miscarriage. It was stillbirth, but that caused the loss. They can experience a lot of guilt, misplaced guilt, and we can contribute to that by what we say. The whole process, everything that they go through, is going to play a piece in that care. I still remember, I'll tell you a story about a nurse that says something to me that I will never forget. When I had my second loss, I had to go to the ED, started bleeding, and the nurse walked in. I had seen many people already by the time that this woman walked in. I had seen a corpsman, and for my people that know military, you know who those are. They're kind of like a medical assistant, everything from like a CNA to an LPN. These corpsmen can be a wide range of skills. And this one, he was amazing, and he came in very caring. I had seen the triage nurse, I had seen the corpsman, and I had seen the provider, I'd seen the doctor, right? I had seen all of these people before I saw this nurse. And she walked in and she said, how many weeks pregnant you are? You're 6 weeks. I wasn't 6 weeks, but mind you, I was 8 weeks, but it really didn't matter how many weeks I was, but how dismissive she sounded. And that I will never forget her. And when I would do bereavement training with the ER, years later, I remember standing in front of her, and I remember looking at her and thinking to myself, she still does not remember that that was me, that this is me, right? Everything we say, they will remember. If we say it, and it's traumatic. If we say it and we don't recognize, sometimes just taking a pause and apologizing can mean so much. So we're going to watch this video. It's only 3 minutes long, and then we don't have a whole lot after that.
Yes, there were days I thought I wasn't going to make it, especially at the beginning. I thought I was going to be the only person ever, because you don't hear about infant loss. You don't hear about, well, at least I didn't.
Oh. Well, we might have to continue on with that. If it starts playing again, maybe we will be able to watch it. Okay. It was an unexpected issue. So with discharge, making sure that we assess their support network. Where are they going? What does the next few weeks look like? The Resolve Through Sharing video does an amazing job of talking about this. They have a video with 2 videos, and it's one nurse that's doing the discharge education, and she is just going down the list. This is what to expect after vaginal delivery. This is what to expect with your laceration. This is what to expect with this. And she is doing her discharge education, and she makes no discussion about the fact that this patient went through a loss. And does not talk to the dad. The dad is sitting there, and he is staring off into space and looks so lost. She says nothing to him, nothing to the patient. She basically forces the moment on the patient and says, okay, I'm going to talk to you, and doesn't talk to the patient about whether she wants to get dressed for discharge or if this is a good moment to talk to her, nothing. And then she comes back in for the video of how it should be, and she comes in and she sits down, and they say, if you can sit with your patient, sit, meaning grab that little stool, put it by your patient and sit. You could spend the same amount of time in that patient's room as you did by standing. And by sitting, the patient perceives it as double or triple the amount of time that you spent with them. Just sitting and being eye level. It's very similar to, you see a child, what should you do? You should get down to their level if you want to connect with them. Being eye level with somebody can just change the whole moment. So she sits and she says to the patient, talk to me about what the next few days, what today's going to look like. What are your plans? What are you thinking? And the patient kind of answers the question. And she gave water to the dad to bring him into the discussion and have him be involved. She asked them, she said, well, family members are going to ask, friends are going to ask about the baby. What are some things that maybe you could say? And let the patient kind of discuss what that could look like, just talking to them about it. She talked to them. I had 2 patients that this piece became very critical. So I did the Resolve Through Sharing course really early when I first became a nurse. And so I've been using those tools for a long time. And I would ask them how long they were going to take off. Were they going to be able to allow themselves enough time to take off? Or are they going to have to go to work immediately? That kind of stuff. What do they do in their job? That can play a big piece in the recovery from this. So I had 2 patients, and both of their stories, I feel like, show why it can be so important to talk to them about it. One patient, she was a kindergarten teacher, and she told me, I'm I'm a kindergarten teacher, and all my kindergartners knew I was pregnant, and they're going to be really excited about it. And I'm really scared about going back and what that experience is going to be like. And so we had talked about how maybe instead of her needing to tell them that she could share it with a colleague or share it with one of the parents, and that her colleagues could kind of let the kids know in a way that would be supportive for her, to where she wouldn't have to be the one telling them. And she, after the discussion, we also just talked about how long she, letting herself have enough time off if she needed it. And what are some ways that she could go about this? And she ended up, she did not go back to kindergarten teaching. She put in her 2 weeks notice when she made the decision, not immediately. I took care of her another time when she was pregnant with her second baby. And she told me that she left kindergarten teaching and she actually went back to school to become a social worker. That the loss opened her eyes to what really needed to happen for bereavement, or not bereavement, but for therapy, for care for patients. Another patient, the 19-year-old, actually, she was a child care provider. She worked in a preschool, and we had discussions about kind of the same. She said, well, there's one or two of the moms that I'm pretty close to, so maybe I could tell them. And that's what she did. When I followed up with her later, I found that we talked about her parents being so not supportive. The moms that were in her preschool rallied around her and became her support system. And so I think just discussing with them about what kind of support they have and the resources they have, and how we can help them navigate this very difficult road is important. Kind of preparing them for things like I said, the reactions of others. If somebody says something terrible, what do we say? If we have friends and family members in there, that can be an amazing way for them to help. The parents should not be the only ones that have to tell people the bad news. Giving them phrases like, we're not pregnant anymore, or saying our baby died. Giving them something that they can say can be powerful. And we'll go back to this at the end, actually. So secondary trauma. So labor and delivery nurses, I'm sure this is not a surprise if you're on this. Labor and delivery nurses have high rates of secondary trauma from perinatal loss, and just from some of the very traumatic events that can happen in labor and delivery. It can be very, very severe. It says 85% of nurses have witnessed a traumatic birth. And my guess is that if we've been in labor and delivery for 5 years, it's probably much higher. It can really hurt us. And knowing that as leaders, as coworkers, as colleagues, as healthcare workers, I think it's important, that we're there for our coworkers, that we're there for our colleagues, that we allow grace, that we allow the fact that you can have some of the worst days ever in labor and delivery, and that we need to rally around that person and take care of them. This is a quote from a journal. It was secondary traumatic stress and moral injury in maternity care providers, a narrative and explorative review from last year. He says, each traumatic birth adds another scar to my soul. Sometimes I feel like the picture of Dorian Gray. Somewhere in my real face is in a closet and it reveals the awful things I've seen during my labor and delivery career. The face I show the world is of an aging woman who works in this lovely place called labor and delivery where happy things happen. I mean, how many of us have felt like that at some point? I feel like it does. It feels like it's as sometimes can feel like a scar in your soul or a cross to bear. Or I will tell you, there was a time, I've been a part of a lot of losses now, but there was a time that I could remember all the babies' names. I will say I do have memories of every loss that I've been involved in. Secondary sometimes after the fact, sometimes talking to them on the phone, but you carry it around. We are gonna go back to this. I'm gonna show you guys really quick. I'm not actually gonna play because we have 3 minutes, so I'm not gonna play the video. I do feel like we have a lot of her video that's still not working. We have a lot of the same resources. We looked at the A1 perinatal bereavement room. I would say ours looks similar. There are some things that we could work on, like getting molds and stuff like that. A1 resources for bereavement have improved. Perinatal bereavement resources. They have now a certificate program, so you can get a certification on bereavement. As nurses, we love certifications. This is that bereavement room tour. So if you want to watch the video, if you're curious about it, there's some checklists within here, sample birth plan, photography tips as well. I think some of this I used actually. So this is like the sepia that we talked about, black and white. Normal positions, like healthy baby position, like not the hands crossed. And some of the other things that we discussed. And then they also had, in the result they're sharing, we definitely had communication strategies, and there's many different places you can get this, but I didn't use some of the things that they said because I thought that summed it up really well. So anybody have anything? How did you guys feel about this first bereavement class? And are there any other types that you would like to see for like the future? Because I figured by doing this one as a 4-hour, we could maybe do another one as like maybe advanced perinatal bereavement or something along those lines. Thank you, Alexis. Is there anything else that you guys would like to see in a future bereavement class? Thank you. Maybe we can look at more ways of doing the memory making. That's probably the thing that I was thinking about, expanding the pictures a little bit more. Or providing resources for it as well. Okay, that is, you would attend another class. Thank you, Kirby. Appreciate that. That is all. I will send you guys the evaluations to your email if you can send it back. And then once it should be published within the next day or two in HealthStream. It's just one person that's able to publish that stuff. So once I am able to get it published, I'll enroll you in the health stream class kind of after the fact, and then the 4 CEs will go into your health stream account. I've verified with my boss, who's actually the person that publishes them, that everybody will get credit for this class, even though I'll have to enroll you in health stream afterwards. So, anybody have any questions? Thank you, Chanel. Thank you, Kim. I agree. Resources it can be such a hard thing to go through as a nurse without knowing it, and I think it's very important. Thank you, guys. I'm going to stay on and make sure I have attendance. Just have to take pictures, screenshot of you guys in the chat. Sorry. It's like one of those things that they look for. I'll send out your evaluations today too.
Anja, are we good to log off
Yeah,
now?
you guys are good. I was just taking pictures of the chat. You guys are good. Thank you.
Thank you.